opportunity to talk about one of our emerging technologies. The speakers this morning gave a great introduction to what I'm about to talk about. In some cases, too good of an introduction. Actually, I'll skip over some of my slides because they've covered some bits of it already. But hopefully you'll indulge me that I may go over one or two bits again that I think are important that you understand the concepts. But you might recall this morning, Professor Nelson, I think it was, that said about how important it was to understand the tools that you're using, and almost, you know, that there's a duty to understand the tools. So hopefully you'll understand this tool a little better in 10 minutes' time. Okay, it was somewhat of a coincidence that it's all worked out like this, that this conference is mostly about flow diverters. And when I heard that I was going to be speaking about emerging technologies, I was looking across our portfolio, and by coincidence, the most recent product that we have launched, we only got the CE mark a few months ago, and we're still kind of scaling up the launch, was this product. You know, if I was asked in a couple of weeks' time, it could actually be a different product. As you can understand, I'm not going to talk about a product that hasn't got approval or isn't in clinical use yet. So the timing has worked well to talk about Surpass today. But we're working across all of our portfolio. And just to remind you again about what it is, it's a braided stent with a high wire count, as I'll show you shortly, made from chromium cobalt, and has platinum in there as well for visibility. And used for aneurysms in vessels from 2 millimeters to 5.3 millimeters. So there's three themes really here, and while the new Streamline product is more about the second two bubbles there, so like Pipeline Flex, we haven't changed the actual device. We're still committed to the design philosophy of the implant, and the Streamline has made some changes and some features to improve deployment and delivery. But I think it is important to still talk about the diversion, because when we went to look at the product again, we could have made some changes to the braid that perhaps would have helped delivery, but I believe they would have compromised some of the core principles of the design. So again, I think this Professor Nelson used some of this terminology this morning, but just to make sure that we're on the same page, I'll just remind people of when I use these words, this is what I mean. So when I talk about porosity, it's the ratio of the metal-free surface area to the total surface area. So it's the inverse of, it's the reverse of metal coverage. So if you hear something like 70% porosity, that means 70% of the surface area is free for flow to occur. And then a related parameter is mesh density, or you might hear it called pore density, or cell density, or hole density, whatever you want to call it. It's really about the density of the openings. So the number per surface area usually is expressed per millimeter squared. And the illustration there just goes to highlight how it's important to understand the difference that both of these diagrams have 50% porosity. So there's 50% black there, there's 50% white, but there's 16 times more mesh density on the one on the left, because there's 16 times more openings per unit area. And that's a key part of our design philosophy. We believe that the higher mesh density takes energy out of the flow and is critical to the occlusion over time of the aneurysm. And so as a result of that, as we go from the 2 millimeter up to the 5 millimeter, to maintain that consistent high mesh density, we add wires. So we add 24 wires there going from 2 to 3, and then we add 24 more wires again as we go from 4 to 5. Just to remind you again, and this was alluded to this morning again, so these are the studies. So the first one there really was more of an engineering study to understand mesh density and what impact it has on flow characteristics and so forth. And then based on that information, the other one was based on rabbit models that were talked a bit briefly about this morning as well. And Dr. Waklu and colleagues looked here and found very interesting outcomes as they varied mesh density. So actually the thing to note there, so particularly if you look at the one on the left and the one on the right, they both have the 70% porosity, but the one with the higher pore density gave much better and more consistent occlusion at the 6-month follow-up. And look, the interesting one in the middle there, even with that reduced porosity, that means reduced flow, but because it had a low pore density, it actually didn't occlude as well or as consistently over the follow-up period. So it was on the basis of this animal study that what led on then to designing products with higher mesh densities and trying to maintain consistency regardless of the vessel size or if the vessel is tapering or not. And then again, this just shows diagrammatically there, so the middle illustrations there are showing velocity and then showing the impacted zone. So as you go from 48, when you add those 24 extra wires here, you significantly reduce the impact zone. If you look at the numbers there, so the interesting thing is there's a big jump from no stent to the 48 wires, a further reduction here, but as you add more wires then there's less and less of a reduction. So for this particular size here, 72 wires would be optimal. This is the slide perhaps I'd like to spend the most time and for you to understand. So pore density is shown here on the left, and picture every braided stent basically is a series of rhombi, which are equal-sided parallelograms basically. When the side square, and if you just do the maths on it yourselves or stick it in an Excel spreadsheet and plot that's rhombus as it goes from completely flat in the delivery system up to square, and in some cases onto a squashed diamond again, the area will follow a parabola, as Professor Nelson said this morning. And mesh density is the inverse of area, so it follows shapes like you see here. And what you'll notice, see on the blue vertical lines there, so for the Surpass devices, and if you look at the labeled diameter, we're landing pretty much in the bottom section of those curves. And if you look at the sensitivity of those curves, so being a parabola, it has quite steep vertical sides if you were to continue those on. So from a consistency perspective, it's much better to land close to the bottom of that curve, because for every fraction of a millimeter that you change in diameter, the sensitivity, the effect on porosity is very little. But as you start climbing those curves, very slight changes in diameter can have significant increase or decrease effects on porosity. So again, this is core to the philosophy of the design of Surpass, is that we selected braid angles that are a bit above square, a bit above 90 degrees in the low hundredths, such that when it's in the vessel, which will be a little bit smaller than it braided and heat set at, it'll be close to the bottom of that curve. And you can afford to get your sizing a little bit out, or if the vessel tapers a little bit, but you're still getting very close to the desired porosity. Whereas some of the devices, as you see there, with less wires, first of all, they have to land typically steeper on the curve to compensate for less wires. So the device is at a steeper braid angle to get more mesh density, but if you don't land exactly on that diameter, your porosity changes significantly. And that's why we've been able to get away with only 17 sizes in total, because we can afford to vary off that diameter a little bit, whereas some competitive products have significantly more products because of the importance of landing on the right diameter. And again, this is just back to a study way back in over 10 years ago, I think it was 2003, based on a dog model that showed that greater than 50% porosity is desirable to avoid occluding the branches. So again, Professor Nelson actually showed a much more elegant illustration this morning there, where he was showing that kind of design window where you want to be above a certain level of porosity, not to occlude the side branches, and then you want to reach a certain mesh density to make sure that you're occluding the aneurysm. So as Surpass was being designed, it was based on the assumption that this was close to the right figure. Our lowest porosity actually is 64%, so we got a reasonable margin. And clinical experience seems to have borne out that that figure is probably in and around right, that we see very little occlusion, or the little that we do see tends to be asymptomatic. So as a design input, it probably was reasonably correct. And then that's just showing there, this is in a rabbit model, so this is the renal artery there, which is quite large relatively, and a very small perforator here, but showing that the endothelialization still occurs across the mesh and leaves the perforator open, and the larger vessels obviously as well. Just two studies here. I think that one of them was talked about this morning. So this is the larger multi-center one, and I suppose the positive figure here really is the almost 75% occlusion at the 6-month follow-up. So again, we believe that very consistent mesh density and it being relatively high, up around the 20 pores or higher per millimeter squared, is helping us achieve that. Even better results there from Dr. De Vries. It's a single center study, but he's getting very high there at 94% occlusion at 6-month follow-up. The other interesting thing there is all but 36 of those patients actually only needed one aneurysm, one flow diverter, which I'll talk a little bit about again. So let's move on to deployment, which is a lot of what Streamline is about. So as we discussed there on the flow diverter, very much about the stability, that also gives control of the deployment. The over-the-wire system has the big advantage of that the wire, you can still re-access the lumen afterwards if you want to reposition or if you want to go in with a balloon or whatever. So that's a significant advantage of the over-the-wire system. And the over-the-wire system allows us to go up to the longest lengths available, which are the 5 centimeter or 50 millimeters. So again, allowing you to maybe use only one device where you might have to use 2 devices if you were using shorter devices. Again, I'll skip over this one quickly, just highlighting again about the stable braid there and so forth, and that it consistently opens. I mean, if you were to play with one of these in your hands, I have a few of them on my desk, and you can really twist them, and every time they'll open because of the characteristics of chromium cobalt and just the number of wires that are there. It's very stable. The radial pressure there is interesting, especially if you benchmark it against the Nuroform. So Fred there being a nitinol, which would have a much lower stiffness than chromium cobalt, which is what's in both the pipeline and the Surpass, is lower as you'd expect. And then the extra wires in Surpass helps to increase the radial pressure there, which again gets better, or more consistent apposition. This is a neat feature on the new Streamline as well. Ironically, because of the over-the-wire system and how predictable it is to place and everything, we find we don't actually need this feature very much. But I suppose a lot of people still are kind of afraid of using these devices, and it is that gives that extra reassurance to know that with this feature, which Professor Taschner showed this morning, you can actually up to 80% after you put it out, 80% still fully retract it and reposition it if you desire. It's a stainless steel little collar underneath the stent that's got radial force out against it, so it helps to pull it back in if you need to. Again, the length story is a good one that you mightn't fully appreciate. So when you look at the length on our label, it's guaranteed that in its final implanted position, it's going to be at least that. It will be over that, in fact. So if you look at it, if you look, say, at these 4s here, so nominally at 4, they're actually all longer than the 40 millimeters length. You'd have to go up to 4.4 of a diameter before they'd actually come down to the 40. So you can be sure, if you follow the label, that when you place the device, that it will be at or greater than that length. Another reason for that is because we're in the bottom of that curve and we're closer to that square braid kind of configuration, there's less kind of expansion that has to happen from the delivered state. So the devices like ours that operate at the bottom, from going from the delivery system to fully expanded, the amounts that the braids have to move is less, so you get less foreshortening. Whereas if you have a device with a much higher braid angle, you can get up to 60% foreshortening, which does occur on some of the other devices. Typically ours is in the kind of 30% range. And then finally then just the delivery here. So just to highlight some of the changes we've made, we've completely re-engineered the delivery system. So you might be aware that we acquired Surpass back in 2012, primarily for the implant. Surpass had gone to an outside company and done a reasonable job in getting a delivery system. But at Stryker Neurovascular, one of our core competencies is designing catheters. So we leveraged a lot of what we know on catheters, used a lot of the Excelsior XT27 technology, put in a bit of nitinol to get the best delivery system. and then we added the retraction feature as well. And as a result of that, compared to the old Surpass, the tracking force is significantly down, which is a significant benefit. So finally, just to summarize what I was saying there, basically the design philosophy has been aiming for that consistent flow diversion by designing a braid where we are at the bottom of that parabola, giving us our consistent high mesh density, the predictable positioning with the over-the-wire system, the low foreshortening as a result of the braid design and always at higher than the label length, and then the consistent opening because of the higher radial pressure and just the stability of the braid, and then those longer lengths facilitating using one device. And in those studies there, you saw that the average was very close to 1 per patient. Gracias.
Any question? Thank you. Next is Space for Covidian. Christopher Moran from Washington.
Wait a moment. Okay.
One question.
Sorry, wait a moment.
At the moment, we would Navian would be probably the best choice. There are some others as well, including our own DAC, but yeah, Navian would be.
Moran?
I would like to ask you, in general terms, which do you think is the main advantage of the Surpass to be considered for use in a difficult aneurysm? Which is the main advantage?
Well, you might see at the end there, I use a lot of words like predictable, consistent, and so forth. And with every design choice, there's trade-offs. So I suppose we've traded off a little bit of delivery ease with that extra metal, but we believe that the price that we paid is worth it. That the consistency that we get with the density and the length, so for longer, merely writing aneurysms, you have a chance to use this button.
Here, right here. Okay.
Our clinical data today is supporting.
You change the length now? You need every time the short productor, or you change the length?
No, we haven't changed the length of the device. No.
This is a problem sometimes.
Well, all braids will foreshorten. That's part of their advantage as well, is that you can stretch them out to get them through a delivery system and then have them come back. If you do foreshorten, you wouldn't be able to get so much metal there. But ours does foreshorten less than any of the other products. More wires typically would mean less foreshortening.
Good afternoon. Would like to thank you for inviting me to have this opportunity. I'm from Washington University. I'm a professor of radiology and of neurological surgery. So while I'm speaking for the company, I'm going to give you a physician's perspective. My disclosure is that I work as a part-time consultant. So I work full-time at Washington University, and I work part-time as a consultant for Covidien Neurovascular, and I also do some consulting for Codman. So you're lucky in the EU. You have the opportunity to have all these devices. And the good part about all these devices is that it brings competition. And competition is the best thing because it makes all of us better And the reason it makes us better, we can take better care of our patients, which all is that matters. So in the United States, we're kind of constrained by the FDA. The on-label indication is aneurysms greater than 10 millimeters in length with a 4 millimeter neck from the petrous carotid to the superior apophyseal segment. Obviously, in the EU, we don't have to worry about that. To give you a little bit of feel for my experience, I've done 153 procedures and I've proctored 262 procedures going throughout the country and throughout the world, teaching people how to use the device. And I will tell you offhand, even though I have that experience, every time I do one, something different, I learn something, and it makes me better that I'm able to take it back home. So I've learned a lot with this device. The other thing is, it's the hardest thing that I've ever done. Much harder than glue, much harder than stents, much harder than any complications that I've had. And the reason is you're using a very expensive device with very difficult anatomy oftentimes, and you can really hurt the patient. So it's really important to learn from all of these cases that you've done. So things have changed in the United States and certainly in the EU. We're having the Flex. It's supposedly an easier device, and it is, and I'll go through that. But what's very important, and the reason I introduced myself as an educator, is that I have learned from training. And I think that's very important, is to have that training with all these devices. So I've observed 15 cases, I've proctored 15 cases, and I've done one case with the PipeFlex. You say, well, how can you go out and proctor when you've never even used the device? Well, what's happened is we have all these training devices right now. This is the replicator. You can see the types of aneurysms. You can get a lot of practice. And I have the opportunity as a consultant to spend many hours in Irvine, California, going across these aneurysms and depositing these devices. There's another system called the Mentis system that has the capability of placing Pipeline and Pipeline Flex. It's not perfect, but it gives you a little bit of an idea of how you're pushing and how you're depositing the device within a particular anatomy. And you can even get the company to make differing aneurysms and practice on the Mentis if you so desired. And the last device is the Ellistrat. I don't have any experience with it, but people who have used it says that it works very nicely. So what's happening and what's going to happen in the future is these varying simulators are going to be how we're going to learn things rather than doing it in animals and rather doing it in patients without having any experience. In Europe, you're also lucky because you have one of the Covidien Centers of Innovation. They have full angiographic rooms where you can do these sorts of device deployments throughout the world. Unfortunately, in the United States, we don't have those, but we kind of jerry-rig them to do what's going on so that we can train. So we've done 7 cases in the United States with PipeFlex. All of them have turned out to be off-label. Some of them are distal ICA, a couple of vertebrals of basilar, and in the ophthalmic, and that was because the physician had missed it with the Pipeline device. All the cases were successful. 3 of them of the 7 were constructs, 2 of them because of positioning, and I'll show you the positioning, and 2 of them because of failed classic, that they tried to place the classic and they couldn't get it there. They've also, since many of these cases were emergent, we also coiled because they're very large, and I'll show you at least one of these right now. This is a 7-year-old boy with this huge distal internal carotid artery aneurysm, huge aneurysm. This is with 6 devices. This is the first one, a couple of more, and then the last one, so they were overlapping devices. Would there have been an advantage to having a longer device? Absolutely. But could we necessarily have delivered it across that? I don't know that. And the only way that we would learn that is by gaining experience. This is our angiographic result with the pipelines across when we finally finished and coiled. This is at the completion arteriogram. Everything is filling. And this is a month follow-up with MRA, probably still some filling within the aneurysm. Now, we're going to make the patient's vision better? No. But we're going to keep this terrible aneurysm from rupturing by treating this particular aneurysm. I'm going to spend a little bit of time on antiplatelets. I feel very strongly, and the reason that it was reinforced in those 7 cases, and do remember with emergent or compassionate use in the United States, if things go well, it doesn't matter. If things go poorly, it counts. So one of the patients was on aspirin and Plavix, and the physicians swore up and down that the patient was tested. Turns out when I get there, My colleague did not tell me the truth, and there was a clot in the PCA. And so we had to account for that for the FDA. So I feel very strongly that testing is important, and acting on that testing is very important. You need to know whatever test that you use. I will tell you that PFA 100 is useless, but if those other tests that you have, and you make them work, and you pay attention to them, that's really good, that they're at least antiplateleted. But here's what I think you need to pay even closer attention to, is the hemorrhages. And my hemorrhages in my patients, I've had 2 of them in the first 10 patients, both cavernous carotid aneurysms, and both under 50 PRUs. Nowadays, I would not treat that patient. I would have waited a couple of days and then treated the patient. So here's my protocol now. I give aspirin and Plavix for 21 to 28 days beforehand, and then test them a couple of days if they're in town. If they're from out of town, it may just be the day before, and sometimes I have to cancel them that day and reschedule a day or 2 later. If they are resistant, I will put them on Prasugrel, usually 30 milligrams loading, maybe 10 milligrams, but we do have a paper out there that would suggest that in those patients with that particular protocol, you'll get in trouble. And the reason being is they have aspirin and Plavix aboard, and you're now adding Prasugrel. And Prasugrel, there's almost no resistance to it. So it's something that you need to keep in mind. With the Prasugrel, with Plavix, we had about a 30% resistant rate when I was doing it at 7 days, 10 days. When I went to the 21 to 28 days, it's maybe 10%. So I'm hardly using Prasugrel at all nowadays. PPIs in clopidogrel, it's always a big deal. The pharmacy will send a prescription, they'll say, what's going on? You're putting this patient, you can't do that. It turns out probably only Prilosec has some effect, but I'll leave them on it and test them. If they turn out to be resistant, then I'll take them off of that particular PPI. So it's usually not a big deal, even though the pharmacy will tell you that it's a big deal. So what have I learned from Flex? I think one of the most important things is support. But I knew that really from Pipe Classic. If you have triaxial system, you can push pretty hard, you can get up there pretty close. I think the microcatheter is important. I think that the Headway 27 can work, particularly with Flex. I use Marksman most of the time because it's very successful. The XT27 outside the patient is very flexible. So if you want to push with that catheter, it doesn't work very well. I mean, you might be able to get it. I think the next aspect is the introduction. When you're putting it into that catheter hub, you're going to feel that little pop, and then as you're loading the device with Pipe Classic, you don't feel anything until you get up pretty close to the cavernous carotid. With Pipe Flex, you feel some friction all the way through, or some force. However, when you go around the cavernous carotid, you don't have to worry. It goes around much, much easier. I think it's important that you load it in. There's a fluorosafe marker. I think it's important that you flush. I heard today about bubbles being everywhere. I think if you really, really flush it, and I flush it for at least a minute, and I think with the Pipe Flex, you even have to think about putting a smaller syringe on your side port and flushing it that way to make certain that you get out of those bubbles. Because if you do a CTA afterwards, a DynaCT or Expert CT, you'll see bubbles or air within the aneurysm if you don't flush it appropriately. I think with opening, it's very, very important. And that is, since, and I'm going to show you this in just a moment, there's some sleeves that hold it on with the Pipe Flex rather than the capture coil. You have to get those sleeves out, away from the end of that. You have to unsheath it enough so that it can move. If you expect it to just pop open, that's not going to happen. And it's very hard for the physicians to understand. I thought that you took the capture coil off. Well, indeed, the capture coil is off, but it takes a while for those sleeves to get off. I think the resheathing with the Pipe Flex now that you can do is very, very easy. It's very important, but it's a little different than what you might think, because you're used to resheathing by pushing the catheter over your wire. Well, you push your catheter over the wire a little bit, but mainly you pull your wire back into that catheter that you're using, pulling it back into the Marksman. I think also when you're trying to recover the device, get back over the wire wherever you need to get because you've decided you'd like to see some things prior to losing access to things. You have to remember that you have to pull your wire off, just like with pipe classic, off of those braids because the catheter will want to get caught. You don't pull it out, you just take a little bit of that tension out. And finally, when you are recovering it, when you're getting that catheter tip near the end where you had to worry about lining it up, you don't have to worry about lining it up, but you are going to feel a little bit of a pop when that wire comes back in. As long as the physician has been warned and understands that, it makes it a lot easier for them. So what's changed? Well, the catheter, the wire has changed at the end. It's a smaller wire and has a curve, 55 degrees. It's still 15 millimeters in length. What's changed in the capture coil? It's been eliminated, and the plastic flanges, little flare, I'll show you them in just a moment, are over that, and it goes over for about 3 millimeters. So the pipe flex is on the left, the capture coil, the current pipe classic, is on the right. You can see that they've eliminated the capture coil, per se. They now have just those wings, if you will. The protective sleeves is what they call them. And also the proximal bumper is a little bit bigger in that there's a capture pad, a recoiling recapture pad down at the bottom, the resheathing pad. And that is about 24 hundredths. And it's important that it's designed for the marksman because you want that friction so that it will resheath. Now what has happened at the expense of having that resheathing capability, you really can't torque your wire because it's just going to spin in it and it doesn't really torque. So that distal end, that you can see the difference in the shape, the 55-degree angle that you now have, and now that resheathing band, particularly that slide on the right, you can see the band, the brown material there. So as you're delivering the device, as you're unsheathing it, you can see the wings, you can see the wings open in this particular diagram. You can't see it under your fluoroscope. You can't see them opening. But as you might imagine, it takes a while, particularly if you're in a small vessel, for those wings to come off. And for it to open, what you might have to do if you're in a small vessel is actually resheath, and you'll see that here is by going forward, with your catheter, you'll push those wings open and downstream, so now that the device can open. This is a diagram and a fluoroscopic image of that resheathing band. You can just get to that resheathing band. In practicality, I've never come that close to it with the flex in the cases that I've seen in Europe and the cases that I have proctored or experienced in the United States. So, with flex, the support is very important. Understanding the device is very important. But there's some new things coming. And very soon, and just approved in the EU, is Pipeline Flex with the Shield technology. And what is that? That's a bonded phosphorylcholine on the surface of the pipeline device. It's 3 nanometers in thickness. It's very, very small. And the important thing is that it's not a coating. Remember last year we were worried about particles, and the reason we were worried about particles, and I learned this just last year, particles are everywhere. No matter what device you have, there are particles in the manufacturing process. You can't eliminate all those particles. So what you try to do is minimize them. Well, with the coatings, you really have to worry about them, and they're much thicker. This 3 nanometer coating is a covalent bond. It's on the surface of the pipeline flex, that's already been constructed, and it goes all the way around it. So now you don't have to worry about those particles. So theoretically, there's 2 reasons to do this, and I'll go back a slide. One is for deliverability, and I'll show you a couple of slides about that. We think that, and the company thinks, Covidien thinks, that this phosphorylcholine will make it more lubricious as you're trying to deliver it. And the second thing is hemocompatibility. And the hemocompatibility is, I mean, thromboembolic events, which is one of the things that we worry about and why we worry about our dual antiplatelet agents. So they've tested the resheathing with the Marksman, and they think that it's about 18% less. I don't know whether in real life that's going to change things. Maybe it will. The problem is we're always comparing to the last case that we did, and the anatomy might be a little bit easier. But here's the theoretic reason that it would be more lubricious, and that is the hydrophilicity is increased. On the right-hand side, you can see how the water drop is flattened as compared to the round water drop on the left-hand side without the shield material. So why improve heat belt compatibility? Well, our complications with coils were primarily thromboembolic. Our complications with aneurysm bridging stents in coils were primary thromboembolic. Our flow diverters, our complications are primarily thromboembolic. So if you can lessen the thromboembolic events, that would make sense. And so they're thinking that the phosphorylcholine will, by modifying the device, keep the red cells away. So the red cells have phosphorylcholine and like materials in their walls, their inner and outer walls in the cells, and they don't want to stick to the surface of the pipeline embolization device. Because the platelets don't recognize that as different, they don't want it adhere, they don't want to aggregate, and perhaps we'll see less thromboembolic events because of that. All the other things we can't change, really. Maybe the hypercoagulable state, maybe by good wall apposition, some of the flow disruption will change. But the only thing that we have that capability of changing is the surface of the pipeline device. So in summary, the Shield technology is a surface treatment. Its goal is to allow you to deliver it with less force. Its goal is to have better hemocompatibility and reduce thromboembolism. Does that mean that we're not going to have to use aspirin and Plavix? Absolutely not. That's the reason I spent some time showing slides about aspirin and Plavix or whatever you decide to use. It doesn't necessarily have to be aspirin and Plavix, but it has to be some sort of antiplatelet strategy. So, no recommendations about changing it. Actually, the recommendation is that you're going to continue. So, this device, this with Shield, the Flex Shield device, will be released and available in Europe in the next probably several weeks. You'll have the capability of using the device. It'll be a limited rollout because trying to make all these devices at any one time is a little bit difficult, but they will conquer that. Thank you.
Thank you very much. Now we have 10 minutes for Codman. They're going to show a new device called the Pulse Rider.
Is the same price?
At least right now it is. and I don't set the price.
I would like to stress the importance of the maneuver you described, especially when you're in small vessels. The maneuver to resheath the device in the microcatheter to properly open the wings. I think that this is a very important point.
I think it takes a little bit of experience where with Pipeline Classic you would just really unsheath. Now sometimes, yes, you would unsheath and you may have to go resheath to be able to get the flaps off, to be able to get the wings off. By the way, the wings won't come off. They've thousands of cycles trying to get them to break off, and they don't.
Any question? Presentation from Codman.
Thank you.
It seems that we don't know how to treat MCA aneurysms. We always need more devices.
All right, good afternoon. My name is Jeff Peters. I'm with Codman Neurovascular, and I want to give a little bit of disclosure here. Professor Tersman from France was supposed to be here today to present out on his case experience with this new device called Pulse Rider, Unfortunately, he came down with back pain, and our R&D person was coming here as well, who developed some diverticulitis symptoms. So the best you got is me. So I represent the marketing department, so you'll have to forgive me. I'm not going to be able to clinic. I want everyone in the room to understand that the device is manufactured and it is also designed by Pulsar Vascular. It's a company based in San Jose, California. Many of you may know the CEO and president, that's Rob Abrams, and if you're attending Val d'Isere, he will be there. So the relationship that Codman has with Pulsar Vascular is we signed a distribution agreement in Europe, and that was finalized this past September. CE mark for this product was obtained last year about this time, and as manufacturing was going, they were trying to get everything ready for the distribution, and Codman agreed to be the sole distributor in Europe. The actual indication of the device is listed on the screen there. I think it's of no surprise to you. This would be used with embolic coils for unruptured aneurysms with wide neck, for aneurysms that arise from a bifurcation location. So let's get into the implant just a little bit. There's four main components that I want to draw your attention to. First off, you have the arch, which is this part right here. The second part is the leaflets, which are really a subcomponent to the arch, if you will. Then the third component would be the mid-body, but most importantly is the stable portion of this device called the anchor. And there are many ways you can define this product, but I want to really just focus on three of those. The first would be determine which one of these devices you would want to use. You have a T shape and you have a Y shape. And then for each one of the millimeter wide arch. And then finally, the indicated vessel range is 2.7 to 4.5. And we have two sizes of devices to fit that range. You have a device that will fit 2.7 to 3.5 millimeters, and then you have a device that will fit from 3.5 to 4.5 millimeters. Okay. So that gives you 8 separate codes, and those codes are enough to help you sort of pick the right size based on the shape, size of your neck, and then also the parent vessel sizes. So you should have adequate number of devices to fit most anatomical situations that you want to treat. Now there are 8 markers on this device, and the devices are strategically located to help you orientate the device in a proper way. Recognizing you're using biplane machines, they are at basically 90-degree angles from each other. That way you have a really good decision about orientation. And although we won't go into all the details about orientating the device and how to read the markers, you can see that it gives you very different views based on the view that you're looking at. So you can ascertain the correct positioning that you're looking at. Common question that is asked is, what is the metal to artery ratio of this device? And this device goes through the same calculations that stents do. And so it's the vessel size, what is going to be the metal to artery ratio. But all I really want to draw your attention to is that a majority of the arch is where a bulk of the material is. You can see that the anchor is very open. It has a very open architecture there. And if you were to look at a side view there, you can see that it leaves the branches that are going away from your aneurysm free of any type of metal in there. So it's a unique design, but most people want to know what the metal to artery ratio is. And there's really no way to calculate this other than through a traditional stent type of calculation, which was required by the regulatory agencies, and that's the number that you see there. The next common question is, what is the radial force of this device? And so that was calculated. And depending on the device that you're testing, the larger device has a little bit higher radial force, and you can see the comparisons to a typical enterprise device that's slightly higher. That should provide a little bit more stability for the device. And then the two final things that I just wanted to draw your attention to was microcatheter compatibility. It's a 21 microcatheter compatible system. It would go through a 27 should you want to use a 27. 21 would be the preferred catheter diameter. And then finally, it uses a mechanical detachment system. There is a dedicated detachment system manufactured by Pulsar, distributed by us. But you can also use other electrolytic detachment systems in your lab. So this is a quick presentation since I don't have cases to review, and I'm sorry that I can't do that, but I don't think I'm qualified to stand here in front of you and talk about cases. I've witnessed cases, but certainly don't have the expertise to talk to you guys about it. So hopefully this will at least give you some insight into the device. If you have any questions about this, how you can gain access to the device, please contact your local Codman Neuro rep or your Cardiva rep. They'll be happy to answer any additional questions that you have. We'll be here through the remainder of the meeting as well. Feel free to pull me aside. I'd be happy to help you with any questions that you may have, at least from my perspective. So I want to thank you and just answer any questions that you might have at this point.
Thank you very much. Any questions, please?
The radiopacity? So it's a nitinol implant with a stainless steel wire. So the fluoro images that you saw is all you see is the markers. You don't see any of the body of the device. Fairly typical nitinol view on angiography.
One more question. Once you've deployed the device inside the aneurysm.
I'm sorry, can you say that again?
Yes. Once you've deployed the device inside the aneurysm, how can you change the configuration of the device?
You retract it into the catheter and give a rotation of the wire. So you don't
rotate
want
inside the microcatheter?
Inside the microcatheter, okay. Yes, sir. And it's, you know, the cases that I've witnessed, it's a fairly common occurrence to at least give it one rotation so that you have the proper orientation. Okay, you're welcome. Thank you.
So we finished this session, and we'll begin with the next one.
distal part of the basilar artery, and you have the collateral circulation to recover the normal anatomy of the region. Next, this is another aneurysm in E1 on right side. Fusiform dysplasia is very difficult to put inside one for the or another stent. Why not to close here? You want and you recover. Next, all is have a fusiform aneurysm, pericardial artery, E1, E2. I put one coil, test occlusion, and you see the collateral, normal collateral circulation, leptomyelian anastomosis. This is in lateral view. This is 3 months later, total cure and without deficit. Next. Another, this is most common situation. You are dissecting aneurysm in vertebral artery. It's possible to close. Next. This is another in the pica. It's possible to treat it with coils. It's possible to treat it with glue. Every time you have the very good collateral circulation and cure the aneurysm with low risk. Next. And this is a complex case in P1, giant aneurysm. This is the anterior view. This is the lateral view. You don't have here posterior artery, no problem. Next, you catheterize here, you put here some coils, you wait, and you add the collateral circulation or total occlusion and 3 months without symptom. Next, another case. Next, and this is typical in pica artery in post-middle region. It's possible to treat it with coiling or with glue or whatever you want. Next, this is in the ICA, blister aneurysm. In cerebral, supracerebral artery, blister aneurysm. It's possible to put the coil and cure the patient and navigate with another devices. Next. And finally, this is another aneurysm. This patient is from Colombia. I have a dissecting aneurysm in the middle cerebral artery, only with one coil here for the collateral circulation, and you are total normal anatomy without symptom. Next, analysis is series of truncal aneurysm. Everybody have the patient. I think now I have a new product, but sometimes I think it's interesting to use the old method, the old technique, the learning the anatomy to cure this lesion. Next, this is a complication in the series. I don't have the complication in our series. Next, in conclusion, in patient with fusiform aneurysm, dissecting aneurysm, separative aneurysm, maybe it's possible to treat it with balloon, remodeling, stent, where you want. Why not to use test occlusion and analysis of the anatomy and analysis of the clinical collateral circulation? Thank you very much.
Thank you very much, Dr. Lopez-Ibor. Are there any questions? Yes.
A question regarding the follow-up on the young patients. There were a few 20 years old, 30 years old. What we see with the sacrifice is development of aneurysms in other parts of the circulus because of the stress of rerouting the flow. Do you think that this could be a concern in the young patients?
Déjame un micrófono. I have another study of the aneurysm in young population. I have about 15 patients. si you are the dysplastic aneurysm, normal is possible you are another aneurysm in another territory. This is true. But the problem is the patient have a lesion to treat the lesion. Maybe 10 years ago, 10 years later, regrowth one aneurysm. I have one case. I have a bigger aneurysm of the siphon and the petrosus region, and 15 years later, I regrowth one aneurysm in the basilar artery. This is possible. This is possible. It's similar when you set up the balloon, test occlusion in communicant antenna.
I think the difference, though, but when you use a flow diversion today and the sacrifice like you do in a bifurcation, for example, what we're seeing is a gradual occlusion, not an acute occlusion of the vessel. And then the collaterals will kick in, but we don't know long term if this will put more stress in the circulation. But sometimes I wonder too, and this is what I'm alluding, is if the balloon test occlusion is good enough to predict the acute occlusion, or a stage or a gradual occlusion would be a better way to go. And that's another, I don't know your experience with how reliable is the balloon test occlusion or the Emmental testing, whatever testing you want to use.
I have occlusion as 6 patients I occluded the basilar artery in the middle part. And sometimes in the patient you don't have the initial collateral circulation, but you put one time, you wait, and maybe 3 months later the collateral circulation regrowth. It's very important to put the patient high hypertension and wait. This is the difficult pathology.
Any other questions?
Question of your lecture. Good this or not good? I think this is very good. Why? But it's simple, it's not expensive, very effective. So I think it's very good for treatment aneurysm after test occlusion. Thank you.
We had problems with occlusion of basilar large aneurysm, and the clot of the aneurysm or the aneurysm kept growing despite of the main artery be occluded. And I think that is an issue with the vasa vasorum maybe is still present because the aneurysm was growing despite of no flow in the parent vessel. There was enhancement on the MRI around on the aneurysm sac, but not flow in the lumen of the vessel. And that syndrome, in that case, you show the posterior fossa, very large basilar, no room for the brainstem. Sometimes you may have to do surgery for decompression of posterior fossa, and I don't know if that even helps. Sometimes you may even have to go to open surgery then.
Yes, in posterior fossa, I stopped, 5 years ago, I stopped to use the flow diverter. I use only the standard stent because the problem with the posterior fossa normally is arteriosclerotic aneurysm, dysplastic aneurysm, you are endolink. And my critical point of the new device is the material is very strong. Why not use the new device with soft device, no radial force, soft device. It's possible to adapt in the wall. The problem when you are straight material, you are every time, it's similar to the aorta, possibility to regrowth.
Thank you very much. Coming up next, we have Professor Shakir Hussain from New Delhi. Talk to us about the peripheral dissecting aneurysms, anatomical considerations, and endovascular management.
Tienes que dar. Llama a Javier Serrano que le dé una cosa que me han prestado. El micrófono funciona. Esto. Dáselo a Javier. Esto sí. ¿Qué? ¿Qué? Está funcionando. Ya, me lo quito. Yo también, muchas gracias. ¿Te viene?
Okay. Good afternoon, everybody. Thank Luis for inviting me here and giving me an opportunity to share our experience. And we have been talking about aneurysm since morning, and aneurysm is by definition, which we understand from the pathological point of view, is the ballooning in the wall of the artery. And what we perceive today endovascular in the endovascular management of these cases, it is not actually the wall that we are seeing on angiogram. We are seeing the shadow of the contrast flowing into the aneurysm cavity. So when we talk about peripheral dissecting aneurysm, which is a subject which we commonly see in rather young patients with subarachnoid hemorrhage. Let's say, for example, we have a case like this, where you have a small fusiform aneurysm and the middle angular artery of the middle cerebral artery. Similar case where acute subarachnoid hemorrhage in the interhemispheric fissure, and on angiogram you find that there is a peripheral aneurysms or contrast appearing in a fusiform manner in the distal anterior cerebral artery. Another example of the similar type, sudden severe headache, vomiting, and subarachnoid hemorrhage. And what you see is a fusiform dilatation within a small secular outpouching from this A2 portion. Another similar case, which is again young patient with sudden severe headache, where you have a blood in the perimesencephalic cistern, and on a MR you see a large phloid area in the mesencephalic cistern here, and when you perform the angiography, you see a pseudo aneurysm of the PCA. Similarly, we have a picture like this. We have an intraventricular hemorrhage, and you do an angiogram, you see a peripheral aneurysm of the pica over here. So if you look at the common features in all these cases, there is an acute presentation, there is a subarachnoid hemorrhage, and aneurysm, what we would call it, is a pseudo aneurysm because there is no wall of the artery here. Is a leakage of contrast in the subarachnoid space. They are located onto the peripheral arterial trunk and not typically like a Berry aneurysm, which are related to the circle of Willis or the major arterial origin. Now, peripherally situated aneurysms are often fusiform, and they reach large or giant size in a gradual substantial percentage of cases. So we are talking about actually a situation which is not a subacute or chronic, but we are talking about an acute ruptured pseudo aneurysm of the peripheral arteries. These are generally arterial dissections, but there are other etiologies which are commonly seen, which are associated with high flow AVM sometimes. They can be mycotic aneurysm, particularly seen with SABE or drug abuse patients. There are sometimes oncotic aneurysms or after cranial irradiation and polyarteritis nodosa basset disease, things like that. There are all case reports which are available. The management option in these cases, which we have learned from our neurosurgical colleague, is the sacrifice of the artery, which is the method and the permanent method, or as Luis also demonstrated in truncal aneurysm of dissection, very robust what we call method of treatment, which is tested for a pretty long period of time. So whether we deal with endovascularly or we do surgically, the goal remains same, that is a sacrificing the artery. So surgeon has to perform the craniotomy and do a clipping of that parent vessel, where he has relatively limitation to judge whether there is a adequate collateral circulation or not. I think endovascularly we can do by internal ligation of these vessels, and we can also perform better understanding of the collateral circulation, sometimes by even performing a balloon test occlusion in these cases where we consider mandatory. So let us look at this case number 1, which is a angular artery peripheral aneurysm in a setting of a patient with a valvular heart disease, but he had no active SABE. So this aneurysm was treated by placement of a single coil, which is a simple procedure, and sacrificing this artery, and these peripheral cortical vessels has very good cortical anastomosis, and they have adequate collateral circulation, generally speaking. So in such territory, there is no possibility that we can perform a balloon test occlusion in this artery, which is about 1.5 millimeters or 1 millimeter in size. This is a long-term follow-up of this patient. After 1 year, there is a stable result. There is no growth of this aneurysm. Case number 2. This patient who had a pseudoaneurysm, the sacrificing the artery, which Louis did reveal in one of the A2 aneurysm case. You can sacrifice this artery, but here the A2 is very large, and in present time, I think it can be easily be performed by stent placement across this dissected segment and putting a small coil, relatively ultra soft in nature. So what we do is that we do a deployment of the stent here. This is an enterprise stent deployment, and this is a small ultra soft coil placement, target coil placement here, and you can have a repair of this this artery completely. Aneurysm like this, obviously, when you do a why we say differentiate from the dark aneurysm, which could have aneurysm nature. Here, if you see, it is into the pericallosal artery, and when you do a microcatheterization of this artery, you can see this segment of the artery is diseased, it is narrowed. So it is a fusiform aneurysm where there is a dissection in this particular segment somewhere, where it has caused the leakage of the contrast in this artery. So in this particular case, before we embarked on sacrificing the artery, we did a balloon test occlusion. This is the placement of the over-the-wire balloon, and we did a less than 0.1 millimeter contrast inflation, and we can easily see that there is a good cortical anastomosis to the pericallosal vessels, and through the posterior splenial artery, there was a good collateral until up to the almost to the aneurysm point from the posterior circulation. So we decided to place a few coils here, just to in these particular situation, our strategy remains that we put a coil and use NBCA to occlude this artery, because this is the best way to what you call occlude the dissected segment. Because sometimes if you do this, just the coil packing over here, you do not know this the proximal segment of this vessel, which might be diseased, which may cause a delayed recurrence of the aneurysm formation in this segment. So we placed few ultra-soft coil here, and then using the same microcatheter, we injected a drop of glue into the proximal artery over here. The coil will not allow this glue to migrate further, and we got a very good result in this case without any neurological deficit to the patient. And this is what after the glue injection, we can have a good collateral circulation. And this is the follow-up after 4 months, a stable result, and this patient has no neurological deficit. Similarly, in this situation, Louis also showed this one of these cases, and I think the best way of dealing with these cases is to sacrifice this segment of the artery. But the most important thing in the management of these aneurysm is that to understand that the PCA has several perforators which are supplied from the P1 and the P2 segment. So particularly if you have an aneurysm which is distal into the pericallosal, the mesencephalic cistern here in the P3 segment, which segment has no perforators origin, you can safely sacrifice this segment. But in the P2 segment, you have the circumferential perforator, the mesencephalon, as well as the posterior choroidal arteries, which needs to be preserved carefully. Now, if we understand this anatomical disposition of this segment, we can safely do a occlusion of this segment without sacrificing the perforating arteries. Now, we did test occlusion into the proximal portion of the P1 segment, and we can easily see that there is an immediate trigger of the cortical anastomosis from the middle cerebral artery, and you can see the posterior cerebral artery that is completely perfused. So we again coil this segment, and the important point is that we always make a small, what you call the internal ligation of the normal artery over here with a very small coil. Because if you do not do this, we have seen in the literature some of the cases that there would be coil compaction and the regrowth of the pseudoaneurysm. So this is following the occlusion of the PCA. You can see all the PCA branches are completely revascularized, and this is on the 3D, good picture on 3D. This is we essentially perform the DynaCT in all these cases after the procedure, which reveals there is no acute insult, and this is MR following the next day after the occlusion of the artery without any acute ischemic insults. So the important question is that in such peripheral vessels, is the balloon test occlusion is an important contributor in the management. It has been seen that it's a good elegant technique, and it gives you more confidence, particularly when you're performing this sacrifice of this artery, which is essentially done under general anesthesia. You cannot judge the clinical equivalence of the occlusion of these vessels. So the point is that yes, in some of the situation you can perform these tests, but we have seen in the from the large experience which we have now in the literature also, and the many other operators, that the balloon test occlusion may not be necessary. The process of dissection itself actually gives rise to a what you call damage to the artery, and it causes vasospasm also in that vessels, which actually already triggers the collateral circulation. You may have an example of this peripheral aneurysm, which may not be, which can be conventionally classified as a flow-related aneurysm, because this is located into the posterior cerebral artery, which is supplying to the AVM, which was asymptomatic. This patient presented with subarachnoid hemorrhage. Normally, we know that flow-related aneurysms they seldom rupture, but sometimes when they are large, they may present with a rupture, and this is a straightforward situation where you can actually coil this aneurysm with the preservation of the artery, and that's what we did. We just coiled this aneurysm and not sacrificing the artery here. So the endovascular treatment of posterior cerebral artery has been published, and this is one of the series published from Netherlands, is of 22 cases over 10 years period, and it has been seen that there was a very good result in these cases, except in 2 patients where there was a mortality because of the poor initial condition of the patient. They were not linked directly to the procedure itself. Similarly, from Rothschild, Jacques Moret, who reported this in 2002, 10-year series of 10 cases, again, practically no morbidity and no mortality in these cases. Coming on to the peripheral dissecting aneurysms of the cerebral arteries, which is relatively more common in terms of peripheral dissecting aneurysms. As said, the dissecting aneurysms of the peripheral vessels are very, very uncommon. They constitute less than 1% of the total cases represented in many large series. Now, it is important that again the strategy in these cases remains that they may be located in the ICA, PICA, or the superior cerebral artery. We will be looking at an example from the ICA firstly. So the important point is that the ICA occlusion, which is usually into the mid-trunk portion, whether it is safe, because there are many perforating vessels which are originating, and particularly with the ICA, it is the internal auditory artery which is usually at risk, and occlusion of the ICA is often problematic in the sense that it causes acute tinnitus, vertigo, and giddiness because of the acute insult to the internal ear. Now here is an example of a patient who came with acute subarachnoid hemorrhage grade 1, and on an angiogram we demonstrated, if you take a close look, there was a very small aneurysm located at the common trunk of the ICA-PICA. On the AP you can see this small pseudo-aneurysm formation here. On a magnified view you can see more clearly. So we went with the microcatheter into this segment of the ICA-PICA, and we can see that this is the PICA trunk that we went into initially. We withdrew our microcatheter. This is the segment of the ICA here. And this is generally a very small artery into the cortical segment or into the anterior, what you call pontomesencephalic segment. It is about 1.3 to 1.4 millimeter in size. And in the cortical segment, in the distal segment, is about 1 millimeter. So microcatheterization is sometimes in a dissection of this vessel is more problematic because there is often associated vasospasm in these vessels. So this we did with the 1.2 magic catheter, and this is the placement of the magic catheter which actually caused the flow arrest in this artery, and this was good in the sense that we could inject a small droplet of glue under very good control without distal migration. And this is what the result was. There was an aneurysm here, and the pseudoaneurysm is completely occluded. However, the outcome in this case was MRS2 because this patient, as predicted, had severe vertigo and giddiness and deafness also. But his symptom of giddiness improved over a period of next few weeks' time, and he could go back to his normal activity of daily living. Coming on to the superior cerebellar artery, it is important to understand when you are sacrificing the artery, the course of the vessels, because it all depends on which segment of the artery the pseudoaneurysm is and where you are ligating this artery or internal ligation is being performed. Conventionally speaking, superior cerebellar artery, similar to the posterior cerebellar artery, is divided into 4 segments, which are anterior pontomesencephalic segment, lateral pontomesencephalic segment, and the cisternal segment, which is into the mesencephalon, and the cortical segment. So on the lateral view, you can see second and the third and the fourth portion much more clearly and better way. Now, superior cerebellar artery also supplies to the perforators, circumferential perforators to the upper part of the brain stem, that is the mesencephalon. So it is very important that we do not sacrifice these perforators when we are occluding these arteries. Now here is an example of a patient a young lady who came with the progressive symptoms of brain stem compression with sudden worsening in the symptoms. And the MR revealed a large mass effect, a pseudoaneurysm with a partial thrombosis, and when we performed the angiography, we found that the superior cerebellar artery, there was a small filling area into this pseudoaneurysm, which was having a delayed filling of the superior cerebellar artery. This is a lateral view. So we did the microcatheterization of this artery, which is relatively a simple job in this situation, but important thing is that what we will do subsequently. So again, I think it is individual choice whether we use coil or glue or any other embolic material. But in our environment, because cost is a major constraint, and we will be talking about in many ways that when you are dealing with these situations, you have to take into consideration the cost-effective approach of management. And because we use NBCA very rampantly into AVM and dural fistula management, we are quite confident about the use of this material, which is, I think, very, very cost-effective. It just costs less than $25. So after seeking this position of the catheter and understanding the flow, speed, and the time taken for the evacuation of this pseudoaneurysm, space into the superior cerebellar artery. We decided choosing our concentration, and we just fill this cavity with the glue, with the slow injection, and you can see that there is a complete elimination of this aneurysm, pseudoaneurysm, and you can immediately start seeing the collateral filling, retrograde filling of the superior cerebellar artery, which is essentially observed through either the pica or the ICA, whichever is dominant. So this is the lateral view, and in the late phase you can see that there is a complete collateralization of the superior cerebellar artery, and patient performed very well. And this is the cast of the glue exactly into the cavity of the pseudoaneurysm and little bit into the proximal part of the superior cerebellar artery, which is essentially the goal, because if you create this tail of the glue, there are very less chances of having a recurrence of this aneurysm in the future. This is the post-embolization CT scan of this patient. And another case example, relatively distal P2 aneurysm, superior cerebellar aneurysm. Strategy is again straightforward. Don't do the balloon test occlusion in this case. Superior cerebellar artery tolerates the sacrifice of the vessel very well, almost 100%. You can be completely confident about it. And this we have seen in any number of our cases, and this gives us good confidence to perform this procedure. And this is, in this particular case, we used the coils, and you can see the reconstitution of the superior cerebral trunk. Pica is another among the superior all cerebellar arteries. Pica is one of the common site for the peripheral dissecting aneurysms. And pica, as there are enormous variation of the origin of the pica, and I will not dwell into the embryological and the anatomical aspect of these variations, which are enormous, which are important in understanding, because depending on which segment of the vertebral artery the pica is originating, you can predict by embryological or anatomical knowledge that what is going to be the origin of the medullary perforator, whether it is going to come from the vertebral artery or predominantly from the pica. So if the pica is originating from the V4 segment, for simple understanding, or as a common remark, I would say, if the pica is originating from the V4 segment of the vertebral artery, then the medullary perforators are going to come from this pica proximal portion, that is the first and the second segment of the pica. And if the pica is originating from the basilar artery, the majority of the perforators, they come through the vertebral artery. So in that situation, the pica proximal segment remains devoid of any perforator, and is relatively safe to occlude this segment of the artery. So I'll go straight to the last example. 27-year-old lady, sudden severe headache, vomiting. What you see is a high blood pressure, neck supple. CT scan, intraventricular hemorrhage, and this is a pica aneurysm over here. Microcatheterization in this size of pica is relatively simple. A flow-guided microcatheter, placement of the tip into the aneurysm sac. The most important thing, we use glue again, NBCA. So important thing is that after microcatheterization, we do a lot of what we call multiple runs of the microcatheter injections, so as to select the right concentration of the glue and the speed of injection of this glue. And this is following the small, what you call about a 0.1 to 0.15 ml of the glue. Again, to demonstrate here on the cast of the glue here, that this is the rounded, filling into the pseudoaneurysm, and the tail over here into the proximal part of the pica, so as to ensure that there is no recurrence in these aneurysms. This is a long-term follow-up 6 months later, a completely normal circulation into the superior cerebellar artery has taken over this territory already, and is a very good adaptation is observed. Last case example, all the dissection which are peripheral into the peripheral territory, do they require what you call this kind of intervention? That's an important question, because many of these dissections that we see in the peripheral vessels are presenting with ischemic symptoms, not with the hemorrhage. So this current what you call vessel sacrificing strategy we take only for patients which are presenting with subarachnoid hemorrhage. But if they are coming with the ischemic symptoms, like in this case, patient, a young man of 40 years, sudden onset giddiness, get ataxia, dysphagia, and hemianesthesia. MRI revealed, the diffusion revealed lateral medullary infarct here. This is a ADC image. And what you see on a T2 weighted image here is that there is a large hematoma here into the vertebral segment. And also into this proton imaging, you can see the hematoma into the wall of the artery. This patient we treated conservatively with heparin, and we did a follow-up again after 1 week, and you see that there is no further embolic phenomena from this segment, and this is what the distal part of the vertebral artery was. So when we did the angiography in this patient, we found that had a dominant PCOM on this side, bilaterally rather, and this gentleman had a dissection of the both vertebral arteries. Right vertebral artery was totally occluded. This is the left vertebral artery. There is a pseudoaneurysm. There is another pseudoaneurysm in the proximal segment of the pica here, and this is the right vertebral artery, which is completely occluded following the stroke. So this caused the lateral medullary syndrome. The patient was neurologically stable. He was not having a further embolic phenomena. We kept him on anticoagulation and did a follow-up. He made a good recovery. And a follow-up angiography, which we did after about 4 months' time, it was remarkable to observe. Of course, the right vertebral artery was completely occluded, so no further treatment is required for this vessel. Important thing is that 2 aneurysms which were there, dissection on the left V4 segment, which was almost mirror image dissection in the vertebral artery, and the pica over here is completely healed up. So the dissection or the fusiform shadow that you see on angiogram doesn't mandate a treatment by intervention. What is more important is that what is the manifestation of this dissection. If the dissection is presenting with the rupture or the subarachnoid hemorrhage, certainly it warrants urgent and immediate treatment by endovascular means, preferably. But if it is presenting with ischemic manifestation, we generally prefer to give at least 3 to 4 months time to observe what the nature does, because in many situations like this, we have seen in many more cases that there is a complete healing of these vessels and resolution of these fusiform, so-called fusiform pseudoaneurysms. So the clinical presentation that we had in this peripheral dissecting aneurysm, which we had 25 patients, majority of the cases they present with subarachnoid hemorrhage, but they also had an intracerebral hemorrhage or a progressive deficit because of the mass effect. These are the different locations. Anterior circulation, we had 8 cases, and 17 cases had into the posterior circulation. PCA dominated by 3 cases into the P2 segment, and P3 segment 5 cases. In cerebellar arteries, we had 9 cases, which were 6 into the pica. And the results that we had was 100% technical success, clinical result 100% in terms of angiographic results. And morbidity, we had in 1 patient who developed a decreased hearing, that was ICAP aneurysm. And 1 patient developed transient mild hemiparesis, which was a P2 segment aneurysm, which improved over several weeks. We had no mortality. So in conclusion, I would say that peripheral aneurysms of the cerebral arteries are relatively rare. They are often seen in young patients. They are pseudoaneurysm. They are not called. They should not be called as aneurysm because there is no wall, and that is why there is no point in repairing those shadows which you see on the angiography. They are often seen in young individuals, and an endovascular treatment remains the best option, and the most robust and the most definitive way is parent vessel occlusion in these cases. And the most important thing in avoiding the morbidity in these cases during the procedures to understand the anatomy of the cerebellar arteries and the peripheral arteries in the as Pierre often used to say, learned anatomy, it is the cheapest way of being the safe. Thank you very much for your kind attention.
Thank you, Dr. Shakir, for this beautiful presentation. Are there any questions?
You had, I'm assuming you're using antibiotics at the same time, do you treat them in an acute phase? I think that's the impression I'm getting here, or you give a chance for antibiotics to work?
No, we treated in acute situation because this patient presented with subarachnoid hemorrhage, and as I mentioned that there was no evidence of any subacute bacterial endocarditis at the time of patient presentation. So he had a valvular heart disease, but there was no active SABE. Maybe in the past he may have had, maybe.
Are there another question? Okay, we continue. Thank you, doctor.
Thank you.
Dr. Leopoldo Guimaraes will talk about perivascular occlusion in Hingham aneurysms and results in a single center experience.
No, ¿dónde está? Hasta aquí, ¿no? 2015. Ahí. Sí. Dale. No, abre la presentación. Definitiva. Definitiva. ¿Entiendo el bloque? Sí. Bueno, good afternoon. Antes de nada, I speak in English, pero antes de nada quería agradecer a mi querido Luis, compañero del alma, esta invitación a participar. I change the subject. I speak about the parenvesical occlusion in giant aneurysm, a study of 246 aneurysma in 244 patients. Hay un problema aquí. Tengo un problema con el ratón y con... Pero que salga de ahí, pero que me obedece. Ahora, ¿no? Y ahora es la derecha. The giant aneurysm represents 5% of intracranial aneurysm. Is a clear predominance in anterior circulation. The most frequent location is in the cavernous sinus. Is the subarachnoid hemorrhage in 25% of cases, rebleeding between 14 and 26%, and surgical mortality in literature 4 to 15%, depending the centers, and morbidity between 14 and 29%. This is some papers related with balloon occlusion in the giant aneurysms. This is our series. It's a clear predominance female between 8 and 80 years, average 52%. The location is a clear predominance in carotid siphon, supraclinoidean, and posterior circulation. We decided in this series to speak about the parenvesical occlusion. It's very important, don't forget this technique. The result is so fantastic, complete definitively, no need antiplatelet. The goal of treatment is to eliminate the mass effect, to avoid hemorrhage, and to occlude the aneurysm. The technique is the patient we treat under neurolethal anesthesia, with heparin, bifemoral catheterization, balloon occlusion, evaluation. For us, it's very important to perform the parenchymography in all cases before and after treatment. This is one patient, the parenchymography described. Complete disappear of intracranial giant aneurysm and normal circulation of the brain. 1 year later, you can see the aneurysm remain complete thrombose in the normal circulation. This patient recovery in totality. This is 3 years later, the same patient. This is another example. The 37-year-old female with occipital headache and dizziness. And you can see some days later, the patient developed a spastic tetraparesis. The remain show a giant aneurysm partially thrombosed. And this patient was treated the same with complete occlusion of the vertebral artery after occlusion test. This is the NMR after. You can see the left vertebral artery show the complete disappear of aneurysm. This is a very difficult case. This all patient was treated by Dr. Sola, Dr. Vivas, Dr. Casasco, and me. And this patient was treated with Calfredo in Madrid. This is a very difficult case with an Italian patient. With giant aneurysm of the tip or basilar artery, arise from the aneurysmal sac. At this time, we decide, realize occlusion test of the basilar trunk. You can see the balloon and the control by the carotid show the revascularization, the aneurysm. At this time, we decide embolize completed aneurysm with coils. And this is the result, immediately result. And the right and left carotid show the revascularization of the posterior cerebral and artery without any symptoms. This is a very complicated aneurysm for treat, I think, another shape. And case similarly to the Luis showed some minutes ago. This is a giant aneurysm serpentine with partially thrombosis. This patient was treated 2 weeks ago with, we perform a trapping. We use a microcatheter distally. We put the coils, some coils plus glue, more glue, sorry, and immediately after, more coils at the origin of the aneurysm. This is the control, immediate control, and you can see the parenchymography before and after with complete disappear the aneurysm, thrombosis. NMR 2 days ago showed the complete thrombose of the aneurysm. This patient is complete asymptomatic, is too early to have the conclusion. Clinically, 20 patients were ruptured and 226 mass effect. The patients asymptomatic 24 and symptomatic 222. The grade, different grade, sorry. In the rupture aneurysm, were in grade 4 and 5 patients. This patient died. The different treatment, you can see the parenvesical occlusion in 213 patients. The revascularization rate at this time, this is the patient, the most of patients, the old patients. In only one patient treated by the balloon, we have the recanalization. This is the patient treated in 97 with occlusion of parent vessel, and you can see the small rest supplied by the vertebral artery. The patient growing, the aneurysm growing 1 year later, and we complete the treatment with coils through the posterior communicating artery with totally occlusion of the aneurysm. This is the control 3 years later, and the angiography with disappear of aneurysm. The morbid mortality in our experience is in giant aneurysm is, we think, is low. The morbidity is 4.5 and the mortality 3.6. 9 patients, in these patients, 5 were grade 4 and 5 rupture. In our conclusion, the grade 4 and 5 is the bad prognosis. For us, it's very important to use the parent vessel occlusion. Normally, the treatment is if the patient tolerates of occlusion, the occlusion test. In 2 months, the patient is complete cured. It's not necessary to repeat the angiography, the antiplatelet. Is in all patients. Before, we use also the flow diverter, the Stensmore coil, all different technique. In the giant aneurysm, we prefer this technique. Thank you very much.
Thank you very much, Professor Guimarães. Any questions from the room?
We use the balloon from Balt, from France, Montmorency, with coax. It's the same balloon that we use since 50 years.
Professor, do you think the presence of intra-aneurysmatic thrombus has anything to do with the safe... Si la presencia de trombo intraluminal tiene algo que ver con un test de oclusión positivo, ¿es un factor predictivo o no tiene nada que ver? Okay, so I just asked if the presence of a thrombus inside the aneurysm sac had a predictive factor for a positive occlusion test.
No. In our experience, no.
Thank you very much. We would like to call now Professor Ricardo Hanel from Jacksonville up to the stage to talk to us about the treatment of aneurysms of the posterior circulation.
Buenas tardes. Luis no está acá, pero quiero decir a Luis muchas gracias por invitarme. Viva Madrid. I happen to give the same talk that my Brazilian brother, much older than me, Demetrius Lopez, gave this morning. So since I didn't have the opportunity to discuss, I'm going to take my time here to discuss his presentation and show you mine. I start thinking about this when Adnan Siddiqui published the horrendous results of the Buffalo series of flow diverter, and our experience has not been the same. And this is my new home in Jacksonville, and it's Mi Casa Su Casa, so whoever wants to come and visit us, it's always a pleasure. It's a teamwork, and we have here with us a Spaniard, Catalan, Dr. Navarro Balbuena. There was a fellow with us at Mayo when I was at Mayo, and now he's in Cleveland Clinic Abu Dhabi, and Ramon is responsible for a lot of the data here. Those are my disclosures. I think Demetrius went through that, and we've seen that. I think you cannot emphasize when you're reviewing the literature on this, what are you talking about? Which type of posterior circulation aneurysm you're talking about? I think there's a lot of confusion on that, and I think we have to do a better job in defining what we're speaking, what we're talking about. For fusiform aneurysms, I like to always try to differentiate between dissecting aneurysms with subarachnoid hemorrhage or not, and dolichoectatic, more atherosclerotic disease aneurysms. I think the best natural Mayo Clinic, and there's a nice evidence that if these aneurysms present with symptoms, ischemic or hemorrhagic or mass effect, the natural history is really poor. And if these aneurysms grow on follow-up, the natural history is really poor. So following these patients, I think, is mandatory, and I've seen, and I'll show a couple of cases here, where these patients just lost in follow-up, seeing interventional neurologist, neurosurgeon, or radiologist with a fusiform, minimal symptoms, and this patient just said, the treatment is too complex, don't do anything. Again, you have to at least to follow these patients to see if these patients grow. Then I think we're forced into situations to treat these patients. So I think it's really important. Another very interesting situation that we're trying to do is to image these patients with MRI. If there is hemorrhage on the thick wall of this aneurysm, it's a very poor prognosis aneurysm. So I think we need to look for better ways to characterize these aneurysms. They remain extremely challenging. Again, when we see one of these beasts coming to our office, you know it's bad news no matter what. And this is a patient that unfortunately was told that this was okay to watch, and she comes back a couple of years later with this type of picture. As part of treatment, she died. I'm going to try to show you a little bit how I mature, or I think I mature, an evolution of the stenting for fusiform aneurysms. I was a research fellow in Buffalo when this case that I'm going to show you here happened, and when I start using flow diverters for aneurysm. This case immediately came to my mind. So this is a lady that presents with not a fusiform, is a focal defect, but a large aneurysm, partially thrombosed, ataxic, from mass effect into the brain stem. And at that point, Dr. Hopkins from Buffalo was just started using, was like a 5-year anniversary. This was 2001 case. Decided to treat this aneurysm with an S7. So put a single stent on that patient. Massive change in flow. Said, oh, we killed that. That's awesome. Let's get out of here. Patient comes back 2 days later with a rupture of that aneurysm. And testimony for the size of his balls, he just put another stent and did not stent the patient because he thought if you're going to coil, this patient, you would create worsening of the mass effect. And 3 years later, he proved the point that he was right. This is a very, very early flow diversion type of picture where with just stenting of a sacral aneurysm, you see that you change the flow in that aneurysm in a way that the aneurysm went away. There's not a single coil placed into that aneurysm. Patient did that well, very well, ended up clipping an MCA aneurysm on this lady. 5 years later that happened. Access used to be an issue, and Dimitrios showed this picture, and I published that. And that's very interesting learning point from that time that we used to do cut downs on the vertebral artery for access is when we succeed, and the failure rate, major M&M for the cut down series with 14 patients is 50%. But when I interview in Buffalo, I will never forget, Dr. Lopez, Dr. Ringer, and Dr. Hopkins were doing a case, and they put a beautiful carotid stent into the basilar artery. When they went to put the second stent, that stent didn't go into the vessel, went through the vessel, and it was game over. So when the patients survive a placement of a tracheal or carotid stent, single device, into this horrendous vertebral basilar aneurysm, the patients did very well. So I think there was a very important message back then, even when we're doing this experimental treatment, putting a groin sheet into the vertebral artery directly, there was a learning there. If you can put a single device, and again, this is a dissecting aneurysm, this is not an atherosclerotic fusiform aneurysm, but if we manage to put a single device there, that'll work really well. And Dimitri showed this case this morning. I'm going to, for sake of time, skip through that. We went through an evolution, and this was very well discussed this morning in terms of using low coverage Enterprise, Neuroform, and Elvis. That's what we have available in the US. In a couple of cases, I've done compassionate use of the Leo stent for that as well. But you see here that we have somebody presenting with progression of a fusiform, partially thrombosed aneurysm that was treated with a telescopic Enterprise. Didn't have anything else to offer this guy. I put 7 Enterprise on this gentleman. And here's a 6-month follow-up. This guy is 5 years out. There is remodeling at the base of the aneurysm, and his symptoms have not progressed. Did I change the flow dramatically with that Enterprise construction? I don't know. There's still some areas of, and he remains on Coumadin because of DVT and aspirin of Plavix at this point. The aneurysm has remodeled, and his symptoms have not progressed. Is this aneurysm cured? I don't know. He's 5 years out. Or so. This was before flow diverters, and he's still there. Again, we don't have this available in the US, but in very, very rare instances, we can write and ask permission to the FDA to use this, and this is before Elvis. Probably today I would have used an Elvis device or a flow diverter. And here you see this patient with this fusiform aneurysm, had a subarachnoid hemorrhage. I thought he bled from this pouch, and I decided to treat him with a low porosity stent and coils. And here you see illustration from one of our papers showing that in follow-up, we treat that pouch, we push this stress on the form, asymptomatic component of that, and we're just watching that. I'm not touching that. I see no reason for that. I think he clearly ruptured from this spot, and so far so good. He is 6 years out of that treatment, and he's doing well. Next 10 minutes, I'm just going to focus in a series of cases that Ramon is going to publish, hopefully in a couple of months, as soon as the review process goes through, with our series of flow diverters for posterior circulation. And this does add probably confusion because it does mix saccular fusiform dissecting and fusiform atheroaneurysms, if you can divide like that. Dimitrios point very nicely about what we're dealing with. We're dealing with delayed rupture, we're dealing with ischemia, and we're dealing with mass effect. Our major problem was delayed rupture, and the patients die from that. So our major concern and focus is on that. I think the Buffalo series treating 7 patients with flow diverter here, mostly all pipeline on the Buffalo series. The average device use was 5.6. And if you think about what you're doing in terms of turbulent flow, just stacking pipelines, you're just creating a very chaotic flow environment. And if you talk to any person, engineer that is study scenario for rupture, if you want to create a scenario for rupture, just stack a bunch of different densities into a vessel, and that's a great way to rupture an aneurysm. Another thing here is, if you're stacking devices, you're increasing mesh density, and you're going to lead to perforator occlusion. Our series, every single case that I've been involved since I started using flow diverter, involved 25 aneurysms in 23 patients, and you're going to see here some of them, a lot of them presenting with brainstem compression, and some of them presenting with subarachnoid hemorrhage. Again, that's the distribution, 12 large and giant, 13 not so much, and that's, for me, a very nice way to treat. There's probably 10 different ways to skin this cat. I decided to treat this patient with a single flow diverter, and on well-opposed single flow diverter coverage of the posterior circulation, we don't have a single perforator stroke. I'm going to repeat, in a well-opposed flow diverter single coverage all the way to the top of the basilar, we don't have a single perforation stroke. We have one patient I'm going to show you here next that I treat with multiple Leo and then a construct of Elvis that is, I think, a very nice way to do what Dimitrios showed you earlier. We don't have Leo in the US, so we use Elvis, and that's what Dimitrios was showing you, Enterprise. When you use high metal coverage, you can have perforator problems, and I'll show you that. But in a single perforator coverage, we don't have that. There's one patient where intentionally to try to use a strategy, single device as much as possible. Intentionally, because I didn't want to add a second device from the top of the basilar, and I didn't think that a low metal stent would oppose that stent one way or the other. I left intentionally the pipeline hanging on a second component of a fusiform, and that patient had a perforated thrombose right at that level because of the malposition. And here you see the single pipeline. This was around Christmas, so we call that the candy cane aneurysm. And I was very worried because this is 6 months later. The aneurysms are still there. I said, I did not do this patient a service. These aneurysms are not going to close. Naturally, I wait longer, and this is 12 months later. The aneurysms, both sides are occluded, superior cerebellar arteries preserved, and angiogram, so complete occlusion of that aneurysm. I hate using flow diverters in rupture scenario. The same thing for stents. I think dual antiplatelet regimen creates a big mess. In some instances, we're forced into that, but sometimes we're not. This gentleman presents to us, was playing volleyball on a Sunday morning, my partner calls me. I have a patient here with a big hematoma. I said, be careful because this might not be a hematoma. CTA shows that was not a hematoma into the brainstem, was the aneurysm itself. So diffuse subarachnoid hemorrhage, poor grade, that was treated with a balloon-assisted coiling and some of the penumbra coils. This patient went through bilateral decompressive craniotomy, PEG tube placement, tracheostomy. All would have been a nightmare on aspirin and Plavix or any antiplatelet regimen that you decide. And we knew if he recovered, we had a good way to treat this aneurysm. 2 months later, we know we left a remnant. This guy was back talking and making great progress. We were ready to put his skull back, so we put his skull back. He had a VP shunt, and then we went for the cure of the aneurysm. We put a single pipeline anchor into the P1, and you see here a more focal problem. Again, this is not a fusiform aneurysm, but just to show you what it can be done safely, in my opinion, with single posterior circulation. You see here a nice separation at the follow-up between the coil, the cast or mass, and the vessel itself. And you see here again this space between that. And I think this aneurysm will ever come back for this gentleman and his cure from that. March a little bit beyond, more towards fusiform. I think, as Kim told us, Dr. Nelson told us this morning, I think it's very important to know which segment you're talking about. And there are more than one way to treat this type of condition. This is a fusiform, likely dissecting vertebral aneurysm, treated with a single flow diverter. I think that's a more straightforward, people would agree to treat like that. This is a defect that is more fusiform. This patient presents with a sudden onset of headache, no subarachnoid hemorrhage documented on lumbar tap. Very concerned. This is right around when Buffalo paper came out. Decided to treat this guy with a flow diverter. You saw a little daughter sac on that aneurysm. So I put a microcatheter into the aneurysm and deploy a single pipeline. I like to oversize pipelines a little bit on the posterior circulation. Kim demonstrated that very nice. And when you oversize, you can decrease the metal coverage and probably decrease the metal coverage on the perforators as well. That I think is very important. Very nice flow, stasis on that. I didn't want to roll the dice on this patient's head. I think there's no problem at all if you decide to put coils on these aneurysms, and I think it turns the procedure safer. If you look at the Intrepid data for giant intracranial aneurysms treated with a pipeline, the risk of rupture of an aneurysm is 4.5%. The 1% or 2% that came from the ASMIT data is an understatement for a rupture induced by flow diverter play. So we've got to be very careful about that. And maybe there's not very good data to show that, but maybe there's the protective effect on coiling, and that's what we decide to do here. The picture would be much sexier if you don't put any coils, but that's not what we're looking for. We're looking for safer and effective treatment. If the picture doesn't look as sexy as just the flow diverter, so be it. So we put coils in that. I think that decreased the dose of thrombus, decreased the degradation of the wall that could be caused by the proteolytic cascade inside that. And this gentleman here, we know through embolic events, 3-month follow-up, 6-month follow-up, 1-year follow-up with no problems. This again, more involving aneurysm. You see irregularities all over. This guy's treated with a single flow diverter. Had access issues, so we decided not to coil that aneurysm because of that. Coming more now to the monsters, I think we're going to see that, and we saw that in our series. If we manage to treat these patients, that could be very well be a self-fulfilling prophecy that you can treat with a single device aneurysms that are less complex, and you treat with more devices aneurysms that are more involved. But if you can manage to treat, and this I see a similarity on that with our previous carotid desperate situation treatment. If you can treat these patients with a single device, you're creating a much more stable change in the flow of these patients. And respect, I think it is very important to token because of the structure of this because of the increased resistance of the outflow that the flow diverter can come. So this gentleman, very symptomatic. This lesion is documented, growing over 2 years. We decided to treat him. Did not manage this very well. A month or so after the procedure, he developed a pulmonary empyema and the thoracic surgeon stopped his aspirin and Plavix. In spite of us preaching to the family and to the patient, don't let anybody touch that. So that tells us how delicate is the balance for these patients. They stopped his aspirin and Plavix for surgery. He never woke up from his operation, probably got hypotensive at that point, and he died from that. I think that's on the tab of my treatment, because if he didn't have that flow diverter, he wouldn't have died from that. Not a direct complication from surgery, but directly related to the presence of flow diverter and need for the antiplatelet regimen. Another patient here, I think I showed this one before. Another one here showing progression of this disease, and I think that's very important. And probably this patient should have been treated earlier. And as we discussed today in the morning, you see this patient progressing from 2006 to 2009. He had been all over the country with this lesion. When he got to us, he was on a wheelchair with a tracheostomy and a feeding tube placed. And you see this lesion here. This was before pipeline. You see here he also had an aortic aneurysm that locked my door there, but I didn't know about that. I did try to, we did an angiogram here, and probably in the process of that, or in our access, we gave his first morbidity that we see here. You see here, but so we decided to come from the arm, and for sake of time, I'm going to jump to that. This gentleman did very well beginning. He reversed his deficit. He became independent again, and this was treated with a construction of Leo and Silk. And you see here, beauty of the Leo is very nice and long device. You can bridge the whole segment, and this is the reconstruction about 6 months later. Unfortunately, this gentleman at 1 year was not with us anymore. He did very well for 6 months to 9 months, and then he started deteriorating again. And he was readmitted with a pneumonia, and we re-imaged him. The aneurysm, in spite of that beautiful reconstruction that you saw here and remodeling of the vessel, the aneurysm was growing from the outside. And he died from that about a year or so later. Another patient, that's the one I told you was missing follow-up. Nobody followed this lady, 2007, trigeminal neuralgia, double vision, gait disturbance, terrible access. We tried to treat her with pipeline. The distal protective coil of the pipeline would not let go. One of the only cases that I didn't dare drop in the pipeline without my distal pipeline open. I tried that 3 times with 3 different 5x35, and I stopped. Patient woke up, had a massive GI bleed. I thank the Lord that I didn't put a pipeline on her that day. I didn't give up. I decided to come back. She was heavily symptomatic, compassionate use of Leo Silk. And for sake of time, you guys are all familiar with that, so I'm going to skip through that. Leo Silk construct. We got much better in access 10 years ago. I doubt we'll be able to get through that with any guide catheter. Now we can. Shut down her right vert. 2 weeks later, 3 weeks later, she had her first problem. There was a brainstem stroke, and this lady had a massive hemorrhage at 30 days post-procedure, and she died from that. This is another patient, massive aneurysm, brainstem compression. I think this patient could have been a good case for occlusion. We discussed this with her, a deconstructive basilar sacrifice by clipping or by coiling. I like clipping better in these situations because you don't leave a mass effect that for the brainstem to suffer from. But coiling is a possibility, and we decide on this case because of the risk of this aneurysm rupturing. If you remember the Intrepid data that I just showed you, we decided to do a partial coiling of this aneurysm. And this patient before that had a VP shunt placed, and I also do prophylactic gastrostomy. I lost 2 patients in my career from bleeding from a gastrostomy, percutaneous gastrostomy post-stenting. So I do on these patients with giant aneurysms. I also do a gastrostomy. Perc trach or trach is pretty straightforward. Gastrostomy is higher risk in my experience. So we did a prophylactic gastrostomy on her as well. This is a 1-week angiogram. And she's doing very well about 10 months after this procedure. What we use as current principles when we're dealing with these aneurysms, fusiform, mass effect, we do prophylactic shunt. very strict antiplatelet regimen control. We try to use a flow diverter on the least involved vert. Sometimes you don't have an option, X is an issue. But if you have two verts that are similar in size, and I'm going to show you this on this case, and the right vert is less involved than the left, we try to do that because that keeps the door open for decompression of the aneurysm, if that is the situation, and that has been our experience in some times. I think a single device has very important message for these aneurysms. And I like to coil sacral component because of the risk of that bleeding, and I'm very liberal to use steroids on these patients. This is again another patient that was lost in follow-up. She was seen another place in Florida, and I was told your aneurysm is too complex, there's nothing can be done. 3 years later, again, progressing symptoms, she developed hydrocephalus, VP shunt on this lady, and is here you see the aneurysm compressing, and here you see she has two good vertebral arteries. Most of her aneurysm, as you see here, is on the left vertebral artery, so I decided to go from the right aneurysm, from the right vertebrae. You see here her 3D injection. You see here flow diverter placed, single pipeline, 5x35, oversized on this lady, elongated from here to there, and the vert was occluded. This lady very interesting because I chose the sickest vert to be sacrificed. She developed a recanalization of her complete occluded vert with coils and onyx. What our colleague from India just showed us, you've got to come to the healthy vessel, and we did that with an MVP plug, just shut down the vert just distal to the pica. We don't have balloons, as we're discussing earlier in the US. MVP does a very good job on that. And this lady is about a year out, and she's doing very well with a lot of resolution of her symptoms. She still has some trouble with her swallowing, but her double vision, her trigeminal, and her gait have improved. She was in a walker. She's not any longer on that. I think in conclusion, I think posterior circulation aneurysms can be treated for diverter in a safe manner. I think we should not throw the towel on these giant VB junction aneurysms or vertebrobasilar dolichoectatic aneurysms. There's no question we got much better on the last 15 years. There's still very, very humbling lesions, and when we look at the complication of these horrendous lesions that involve the whole vertebrobasilar in our series, about 30%. It is already a little bit better than the natural history within 2 years. So I think that has to be a very, very, very candid discussion with the patient, what we may try to accomplish. If they live more than 6 months, I think they have a good chance of continue to be with us. No question, there's a lot to be learned. This to Dr. Nelson this morning. I challenge a lot of people in this room. I think we should have a registry for this. I think there's no reason why we're doing all this separate. I think Dr. Lopez, Dr. Sekige, anybody that is interested, I think we should put a series of these patients and decide a way to treat that as a group and follow that for 2-3 years and then reassess, because they're very rare for any individual center, but I think we need to study it as a group to progress. I'm in charge of organizing this meeting today with the Buffalo group. Adnan Siddiq and Elad Levy were very kind to invite me. If you're coming to Chicago for the WLNC, I think it's a great combo. You go to the first meeting, take a week off, summer in Chicago, 1 hour flight to Jackson Hole. It's a beautiful place right next to the Yellowstone Park. You can see the Grand Teton Mountains, nice pictures of the Yellowstone, a lot of wildlife. I think it's a pretty dual punch. WLNC Chicago, 3C, enjoying the summer in a very nice part of the United States. Again, Luis not here, but the organizing committee, muchas gracias.
Thank you, Ricardo. Hanel, have a question?
Ricardo, I don't think that we disagree on the issue of the sacrifice of the contralateral vertebral artery. In principle, if I had placed a flow diverter across the whole aneurysm, I would not leave the vertebral artery open. I think that if you do a hybrid approach, you rely on the less coverage to the escape valve for that. So I think that there's no question that there is a risk to close the door and let the fire hose open in there. It's gonna bleed, of course. But I think we consider that. What I'm more concerned about is that you showed that clearly. Even your Enterprise that one, the contralateral vertebra is not occluded. And I think your Silk and Leo, it didn't look like on one of them, the one that bled afterwards, didn't seem to be occluded on the other side. So, okay, but I think the point is that it's more like to raise awareness to how to control the thrombosis of the sac of the aneurysm. And we felt that I could follow the risk of rupture was not as high if you left a hybrid construct, so I could wait and do that occlusion at a later time. And it leaves the door open to coiling too if you wanted to place coils later on. So I think that part, I'm not necessarily sold that this is the best approach, but I think this at least seems to be safe to do when you leave a hybrid construct. I would not do that if it's a complete occlusion of the aneurysm.
Yeah, we're discussing this earlier. It's probably why it works. I'll be very concerned if I have a flow diverter construct covering both ends of a fusiform aneurysm, incorporating the contralateral vert. To leave that alone, I think it's playing with fire.
The MVP we used an MVP to occlude a vert the other day, and it didn't occlude. It was still going to flow through. Probably was going to thrombose over time. But I was really worried about that. It's like,
yeah, it's interesting that you said that. I didn't show you that, and I should have said that for full disclosure. So what I did, I put an MVP, coil, MVP.
Yeah.
So just like safety belt, I think the MVP needs that too.
So that's exactly what happened. We had a mismatch, so it's a 3 and coil and then a 5, and that was exactly. So alone, I wouldn't put that alone there.
I agree. You're asking too much from the device.
Ricardo and Demetrius, what are we doing with the fusiform basilar where we don't have apposition of our device within that portion of the basilar, or that the basilar is 7 or 7.5 millimeters in size? What are we doing with that? Are we just letting it hang in the breeze, or we're choosing not to do them?
I like Siddiq's idea of coiling to push the flow divert against if you have a major vessel on that. And Dimitri showed a nice case today that probably he covered the other vert, one of the cases that he didn't sac the vert, but the flow divert was right next to that. So I think there is a place to displace this flow diverts towards larger branches. Again, can you oppose on a fusiform to the whole wall? The answer is no. But I think that's the nature of the disease. Again, you have to bridge a large gap of vessel that has no wall with a mesh and stay on aspirin and Plavix. And hopefully in the future, I'd love to see one of these fusiform OCT to see if we can see the endothelial growing on that to eventually stop aspirin and Plavix. That guy that I showed the growth, I don't know. That's a phenomenon. Our friend from Essen, René Chapeau, showed a couple of cases. What is the mechanism for that? Is that we're just not seeing? Because if you do an MRI, you see clot, you see thrombus that is fresh into this aneurysm. Where is this coming from? Is this coming just from vasovasorum or that? So I think the answer we don't know. But I think you have to leave a segment unopposed, Chris. There's no option.
So you were going up into the PCA and bringing it back down, or wherever you can get apposition. And then do you see where, with delayed films, that it's now opposing, or it's still always flapping in the breeze?
No, you see, I disconnect already, but you see remodeling. You see this gentleman that I'm talking about, Leo Silk, and you see others where the vessel does remodel, and some of those little perforators, they come with the vessel wall. They remain paved.
I agree with you that I saw the remodeling, but there was still separation from the walls and the walls. There's still contrast on the outside.
Yeah.
And does that bother you? Aspirin and Plavix forever? Does it change in 2 years if they make it past that 6 months?
Yeah. So this lady that I showed you here, the last one, clearly she has a segment at the bottom of the right vertical construct that you see pipeline and contrast on the wall. I don't dare stop the Plavix on that. Istvan showed us in Val d'Isere last year a very, very humbling case. I think the patient was like 2 years after, and the patient died, and he does a study that there's still areas of the pipeline that are not endothelialized that far out in a fusiform aneurysm. So I think I like to be conservative, and I don't like Plavix as a surgeon. When you deal with this in the OR, it's a nightmare. But our cardiologist colleagues are much, much more aggressive than that with us. And on their literature, they get away with that a lot of times. So I think we have to be very, very careful when you decide to stop Plavix on this patient, because you saw here, naturally was an early discontinuation of the Plavix. That can be devastating, and there are plenty of examples of that in literature.
And so one final question on that. So you're opposing it distally in the PCA or the basilar, but then usually as you deploy the device in an area where it's unconstrained, it foreshortens quite a bit, and B, when it foreshortens quite a bit, you're getting the counter aspect that you would like, because now your porosity is decreasing because your cells are closer together. And how do you avoid that?
So, go ahead.
So the flow enters into the flow diverter, and if later on it comes out into the aneurysm in a low coverage distal, but you are seated with the flow diverter in the proximal segment. And the longer the hybrid construct is with the lower coverage, it constrains your device in the fusiform segment, so you have a more predictable, and also more stable bridge. I think those are the reasons that also helped. I think the concept, so was the control thrombose of the aneurysmal sac, but also a more predictable or selective placement of the flow diverter with good opposition proximally. Even if the enterprise were long enough, you would start the flow diverter proximal to the beginning of the enterprise. And then the distal part, I don't think it's going to be a big deal, the distal part, but the proximal, yes.
I think hemodynamically, it will be very interesting to do this with even with all problems and caveats of CFD. I think you're creating irregular mesh density, and I think this could, again, you have experience, I don't, as much as you do, using this strategy other than the Leo Silk that is a little bit like that. But when I use Leo Silk, the silk is covering the whole area of fusiform segment. There's no area that I'm targeting. Maybe there's fusiform area beyond that I'm not worried about that part in terms of mass effect that I don't target with the flow diverter. But all the area that I'm targeting, it's covered with a flow diverter. What I use for that, Chris, if I can do just with a single device, I don't have that issue. And you saw a case that I showed you here that I put one. What I try to do, and we do that very often where we create a construct, put a second pipeline further distal and try to drag the first one using the second one to stretch the first device. And that's exactly what I showed in that case that died from the pulmonary empyema, that I'm trying to drag the other device to decrease that dense mesh there, and I disconnect number one from number two, and I bought a number 3 device for this patient.
And then you have more overlapping there, though, right? Then you have 3 devices to overlap, maybe.
Again, I wish I had a 5x70 flow diverter that I could put and cover the whole thing with a single device. That's not there yet. There's a need. We have all this beautiful, and again, we don't have opportunity to use the Surpass in this instance yet. Probably Surpass will have the longest single device that may allow. I've seen a case from Sakai that he put a beautiful single device cover from the top of the bladder to the vert. I think that that'll be interesting to see that.
Okay. It's a little bit late. We're going to continue to the Magistrals Conference. Paolo Zamboni, doctor. We talk about extracranial vein of pathology, a potential contribution to degeneration. There are coffee break, but if you want to take a coffee and try here, it's okay.
No, that's perfect. So this is for, okay. Okay, ladies and gentlemen, thank you very much. Intracranial aneurysm. The jump is to go to the extracranial venous pathology. The spinal cord associated this in the scientific way responded, as you may see, with a lot of editorial and commentary against this vision, but with a very strong group of people vascular or neurovascular background that are interested in working in this direction. And in fact, the evidence of the extracranial venous pathology is growing because pathology is still the benchmark in medicine. It's not an opinion, it's not an editorial, it's not a commentary. And what we know now is that any lower of the CCSVI jugular wall exhibits abnormalities with respect to control tissue. So it's a vascular pathology. In the intimal lower, we have loss of endothelial cells. In the medial lower, there is an excess of type 3 collagen with an inverted ratio between type 1 and type 3 collagen. And in the adventitial layer, we have calcification. Calcification exactly having atherosclerosis. This beautiful electronic microscopy shows in control vein in the top panel, you may see a very regular disposition of the endothelial cells as compared to the bottom panel, where you can see the irregular surface of the endothelial cells in CSVI condition with crater and disruption in many points. Looking at the jugular valve, a jugular valve in this condition are frequently not mobile, are stuck valves, and sometimes are inverted. Look at this picture. I don't know if this does not work. However, the pocket of the valve in the second figure, the pocket of the valve is inverted because it's directed against the flow coming from the brain, and this may cause really obstruction or restricted venous outflow.
and the big delay in the venous circulation. Look at the bottom panel. This is the magnification of the stack valves, and the stack valves does not exhibits any endothelial cells at any magnification. So it seems like a fibrous tissue, something really different from control tissue. Ultimately, this is a Nature scientific reports, a group coming from 3 different countries, Australia, Italy, and France, demonstrated the presence of hypercalcification in the adventitial layer of a jugular vein in a CCSVI condition. Intraluminal obstacles, defective valves, but also compression is a further cause of CCSVI and often is associated with intraluminal defects. One of the most characteristic cause of compression is the omoioid muscle. You may see in the figure at the bottom of this slide that there is no intermediate tendon in the 2 bells of the omoioid muscle, and this creates an entrapment of the jugular vein. This can be really very well imagined either by ultrasound or by MRV, and this is called the pencil tip sign. There are many critical points because pathology is very clear, but it's not mirrored by standard imaging methodology to identify CCSVI. Doppler ultrasound studies show a big variability. So from 0 to 100% in more than 24 epidemiological studies performed by using Doppler ultrasound, there is a big variability. There are 3 meta-analyses showing the prevalence of CCSVI in MS, but maybe due to this variability, this is certainly one of the critical points that now we have to front. MRV is very accurate for wall stenosis, for compression, but is not capable, unfortunately, to image the intraluminal defects. The majority of interventional reports by the means of catheter venography clearly show a big prevalence of CCSVI in these patients, but there is a very important study published on the Lancet that I show in some minutes that challenge this vision. Finally, IVUS seems a gold standard, but unfortunately is invasive. This is the study which was published last January on the Lancet, and is a Canadian group, confirmed the elevated prevalence of venous narrowings in patients with multiple sclerosis, 74%, but in the same time, the author did not assess a significant difference with the control population. However, they used a criterion for assessing stenosis never used in literature and never quoted in the journal. They assessed a greater than 50% wall stenosis by comparing not the segment preceding the narrowing, but the entire jugular vein measuring the narrowest and the widest diameter. Clearly, the diameter in normal people, the jugular, on the right, the maximus is 2, and the minimum is 1. Exactly 50% stenosis. On the left is 1.8, 0.4. So in normal population, it is normal if you should compare the narrowest with the widest point of the internal jugular vein, you find stenosis. This is the reason because the proposed methodology was completely unable to separate healthy controls from MS. This is an angiogram. In A, you see healthy subjects, and you see the jugular in the region called the bulb is certainly more than 50% greater respect to the segment at the level of the foramen or at the level of the outlet with the subclavian vein. So this is normal to have more than 50% stenosis. But if you look the CCSVI case, you see in the junction a septum that creates an obstruction of the vein without any reduction of the wall because it's an intraluminal obstacle. This creates a great delay in the activation of collateral circulation. To overcome this kind of problem on the jugular vascular and interventional radiology, this group proposed to standardize the flebogram in terms of volume of injection, time of injection, number of frame, and they found in normal cases less than 2 seconds to have the clearance of a contrast dye, more than 4 seconds in about 80% of people with MS, with a big proportion also of patients with more than 6 seconds. I think that, and I recommend to everybody who is interested in this field to use this kind of methodology because this evaluation is certainly more reliable respect to calculation of the rate of stenosis. Also because, as I showed you, the majority of cases are obstruction due to compression or intraluminal obstacles, and not wall stenosis. Today, what in CCSVI did the investigator really assess? One is what I show, the light clearance time of the jugulars, and this can be also done, as showed by Mancini and other, and Monti, by using bubble ultrasound. So contrast for ultrasound. You may inject in the arm and you may calculate the time of clearance of the jugular vein. Increased collateralization. This was mainly due thanks to a two-dimensional MRI and also with quantification ultrasound. And practically in normal people, we have more than 85% of the inflow to the brain that is drained to the jugular and the vertebral veins. To the contrary, in CCSVI condition, more than 50% of the inflow is drained by the collateral circulation. Increased brain outflow resistance, and also restricted brain venous outflow even in favor of gravity. Step by step, there are a lot of investigators that found that extracranial venous pathology is more and more associated to neurodegenerative disorders. No more the first model of multiple sclerosis, but Alzheimer's disease and brain aging. Quite recently, Parkinson. A lot of paper about Meniere and also sudden hearing loss. Normotensive hydrocephalus. So the question is, what are the unifying mechanisms that may concur to neurodegeneration in so different pictures? What we know is that CCSVI impact the pathophysiology of the brain, especially in two aspects. The first one is impaired CSF flow dynamics. And the second one is brain hypoperfusion. Both aspects are very important part of the pathogenesis of neurodegeneration and are strongly influenced by the venous drainage. The production of the CSF flow at the level of the choroid plexus is not influenced and was not measured any difference with respect to control people. But to the contrary, at the level of the reabsorption into the superior sagittal sinus from the subarachnoid space, there is certainly differences. And this is due to the physical phenomenon of a reduction of the gradient of pressure. Because if you should have both the jugular that are obstructed, you have a significant increase of the pressure in the sinuses. CSF reabsorption depends exclusively from a pressure gradient. To have reabsorption, you need of 5 millimeters of mercury of differences between the subarachnoid space and the dural sinuses. And the velocity of the reabsorption is 0.1 milliliter per minute, each millimeter of mercury of the gradient. Of course, if you should have increased pressure in the dural sinuses, the reabsorption is low. Normal CSF proceeds forward during heart systole and backward during diastole, as you may see. And we calculated that in MS and also in other disease, as I may see in a minute to you, there is a significant reduction of the fluid dynamics. But much more interesting for neurointerventional perspectives is if you should measure the CSF flow dynamics after PTA, this is a control study done in Buffalo, you may see that there are two groups of people. A group was treated and the other acted as a control group. And with the treated group, there is a significant increase in flow and in velocity of the CSF after ballooning the internal jugular vein and the avagos vein if CCSVI was demonstrated. This is a very interesting study because it's a pilot study. It's a pilot study that really is a lesson learned from the pathophysiology point of view because demonstrate that the reduction in flow and velocity during neurodegenerative disease is linked also with the venous function. And this can be correct by intervention on the venous part of the circulation. Is stagnating CSF an important piece of the puzzle? There is an inverted relationship between lesion load at MRI in MS cases and CSF flow velocity. This was published 2 years ago in the Journal of Magnetic Resonance Imaging, but probably more and more interesting in clinically isolated syndrome that sometimes is the onset of MS, and about 50% of people do not proceed to episodes, clinical episodes, if you should have a reduced CSF flow, your probability to progress into clinically defined MS is significantly greater. And also, the same group published that slow CSF flow increases also the lesion load in Alzheimer's disease. So it seems that a good flow and a good velocity of a CSF should be an important piece of the puzzle. The second point, the second G, is hypoperfusion. Brain hypoperfusion in multiple sclerosis is a fact. But hypoperfusion certainly is not related to autoimmunity, but an answer to hypoperfusion. In pathogenesis is very important. This is a fantastic study on brain where the relapsing remitting people were followed up by the means of MRI every 2 weeks. And this showed clearly that hypoperfusion precedes plaque formation. You may see that there is hypoperfusion measured approximately 2 weeks before the appearance of a new lesion. The consequence of hypoperfusion in MS are a condition that has been defined by Bruce Trapp as virtual hypoxia and is behind chronic necrosis of demyelinated axons in MS. But also, there is a great susceptibility to oligodendrocyte to hypoperfusion. So the probability to remyelinate, to repair the lesion in MS is impaired in hypoperfusion condition because the oligodendrocyte synthesize less myelin. In fact, this is a study performed in Harvard by fusion imaging technology of MRI and SPECT, and show that plaques are localized exactly in the brain region exhibiting hypoperfusion, but also in regions with good perfusion. The same group of investigators showed repair and remyelination. So it seems very important to maintain a good perfusion in the brain in order to increase reparation and regeneration due to MS. So the key question is, may cerebral perfusion be improved by increasing the venous outflow? Because everybody are focalized in arterial inflow when considering the perfusion of the brain. There are no studies investigating if perfusion can be also due to delay in venous drainage. This is a group of patients operated, and you may see the respectively the pre and post-op flow in the internal jugular veins and the rate of the collateral flow respect to vein flow. And you may see that we may obtain a very good increasing of the venous outflow through the main routes and a significant and dramatic reduction of the collateralization in the post-op. In the same group of patients, we measured the perfusion by the means of SPECT, and the first histogram show you the hypoperfusion respect normal controls in this group of patients. In 60 days post-op, you may see respect the same group of patients of controls, the significant reduction and improvement of a perfusion. Just the case to see You may see the SPECT in this lady of 45 years old with the cold and blue color of hypoperfusion. Inflow, the brain outflow is written, and you may see that the collateralization dramatically reduced from 80% to 11%, and the flow from the jugular from 200 to 1000 milliliter per minute. And this corresponds to this map of perfusion, where you may see diffusely the warm color of better perfusion. So certainly, this is a big news. You may increase perfusion, especially in people without any kind of problem in vein flow, by acting, improving the outflow. Balloon angioplasty. Is open vein repair or maybe devoted stented needed? We think yes. This is the survivor analysis curve of our first group of patients published in 2009. You may see that there is more than 50% of failure of balloon angioplasty. And we revised these cases and found that PTA failure is due to the presence of long, not mobile, and asymmetric leaflet, because when you inflate the balloon, you lift up the leaflet and do not obtain any notable effect. Also, in case of compression, balloon angioplasty is completely useless. Is effective only when you have short, stack, and symmetric leaflet at the level of the junction. So also technique needs to be improved. This is a summary. Pathology landmarks clearly show a diseased vein wall in CSSVI. Thus, it is a vascular disease. Transit and clearance time through the IJV route is significantly prolonged in CSSVI patients. CSSVI is linked from a pathophysiology point of view to both hypoperfusion and reduced CSF dynamics. To fix flow in the IJV permit to improve both brain perfusion and CSF dynamics. The higher jugular flow and hypoperfusion of the brain may represent a selection criteria. I want to add that exactly the last week of this year, we finished a double-blinded controlled trial in Italy, experimenting safety and effectiveness of balloon angioplasty in this field. So we have 1 year to conclude the follow-up of the patients, and this will be concluded within 2015. So in early 2016, we may have more information thanks to this randomized controlled trial. So thank you for your attention.
Thank you for your interesting talk, Professor Zamboni. Is there any question in the audience? Yes, please.
My question, what do you think about AVI malformation? Patient live 30, 50 years with this chronic hyperfusion of brain, with big pressure in venous system, with retrograde flow, with venothrombose, and patient without headache, without symptom, and live many, many years.
This is a very good question. I think that there is certainly a limit in this kind of procedure because, for example, in the randomized controlled trial that I mentioned, we limit in the inclusion criteria to people with less than 10 years from the with a disability score permitting us to measure the working ability. So the first results will come next year in a very specific group of patients where maybe there could be some probability to have some recovery of function, or maybe to reduce the aggression of the disease thanks to better perfusion, or for the pathophysiology that I showed you. I think that in people with very long and chronic history, with remodeling of the brain with connective tissue and changes like this, it's very difficult to think to have something to do.
Hi, I'm a patient actually of MS, and simply my question would be so direct like this: why is every neurologist I've spoken to against your procedure, or telling me, recommending me not to get that technique or try it even? Sorry.
I don't know, because maybe I am not the right right person, so probably you have to ask to the neurologist. But what I would say is that we cannot stop the research activity. I do not treat patients in the hospital out of controlled trial, of controlled studies. So I am interested in research, and I think that research may offer an opportunity at the end of the travel, of the trip, of the research. What I think is not right is try to stop the researching course with ethical committee and IRB that approved the research. So this cannot be done. And before to express any judgment is a prejudgment. You have to wait for the end of the research.
Professor Zamboni, besides of the controversial about the results, about the frequency of the venous insufficiency, of the not very good results in the short trials, how can you explain, looking at the multiple sclerosis patients, looking at the diversity of the clinical picture, you can see patients with very benign forms, only or 2 episodes alive, patients with progressive, patients with almost exclusively lesions in the cervical spine. How can you explain with uniform pathophysiology this diversity in the clinical?
Of course, I don't know everything, but some important news between the correspondence in topography of lesion and symptoms and topography of the extracranial vein draining a specific area is very well described. What I found very interesting is that patients with primary progressive MS are patients with mainly paraparesis, spastic paraparesis, and mainly lesion confined in the spinal cord, with very few lesions in the brain. What I found is practically any possibility to have procedure is impossible, because this kind of patients, in my experience, show aplasia or hypoplasia of the extravertebral plexus. And this is the cause of a venous return along the spine without any possibility to reach the adagos system and the caval system through the extra spinal venous plexuses. I think that this is very important because is a biomarker of why there is a primary progressive respiratory relapsing remitting or a secondary progressive cause. I think that this is a very important thing that unfortunately nobody performed lumbar and ascending lumbar and selective venograms, adagogram in primary progressive multiple sclerosis to have reproducibility of this data in other center. I think that this could be done. It's very interesting.
Well, this is an interesting observations, but one aspect of the disease that we see in the intracranial venous system is veno-occlusive disease, particularly following venous sinus thrombosis. And there is a group of patients who present with benign intracranial hypertension. Right? They have venous stenosis in the transverse sinus or sigmoid sinus. And there are reports that when you do a venoplasty in these areas, there is a dramatic improvement in the symptoms. It's the same hypothesis basically. The only difference is that it is an intracranial occlusion as compared to what you propose, that there is an extracranial venous system which is getting affected. Now, there's another point of very important concern here that, of course, there are a contradiction to the hypothesis that whether the venous stenosis in benign intracranial hypertension is a cause or the effect. Because every time that you do a venoplasty, it doesn't resolve the intracranial hypertension. That's one point. The second important point is that we do see in many restrictive diseases or particularly again in relation to veno-occlusive disease. Again, spectrum commonly seen in the young and middle age. The venous drainage system of the brain has an enormous, what we call adaptation to go through various routes. Commonly that we see in dural venous sinuses occlusion, it adapts through the pterygoid plexus system and through the ophthalmic system, which acts as a buffer to adapt to the venous outlet. So if it is the mechanism that there is a occlusion of these extracranial venous systems, why those alternative adaptive mechanisms are not operating in multiple sclerosis?
Okay, the first question is cause of effect. It's a very good question. I will discuss with the first point, remembering pathology of the venous wall. The group in Geneva is a group of pathology, studied the jugular vein and did not find any type of T lymphocyte in the wall. So if this was an effect of a MS, you have to expect infiltration, autoimmune infiltration in the veins. And the pathologist told us that there is no infiltration. There is a change in type of collagen. Can be due to MS or to Parkinson or to Meniere? I don't think. And calcifications in the vasa vasorum, I cannot think that this is an effect. Maybe is another aspect of the disease, but it's not pathogenetically linked with autoimmune disease or immune system. The second is very interesting. We developed a transcranial Doppler approach to the condylar veins and showed that in case of optic neuritis, there is a greater chance to have here the petrosus sinus and in the cavernous sinus bidirectional flow. And usually this is monodirectional flow. Bidirectional flow means that there is a part that is drained through the orbit, the very obvious hole, and there is a lot of circulation through the pterygoid plexus. But also, according to, I have not time enough to show everything, but there is a beautiful paper in the American Journal of Physiology published last November, showing from a group of mathematics and physiologists, showed that in case of the double obstruction of the jugular vein, you may have this shunt from the arterial part of the brain to the meningeal through intracranial anastomosis, and this could be the cause of hypoperfusion. And this because the increased resistance in the venous system allow a shunt from the parenchymal arterioles to the meningeal arterioles. In fact, when we measure the return, there is a big discrepancy between the flow in the external carotid artery and the collateral flow. It's not coming all from the external carotid artery. So maybe could be shunt through extracranial anastomosis, and this may be the cause of the hypoperfusion.
Thank you. It's a very interesting discussion, but we need to finish. Thank you very much for Professor Zamboni. It's time to invite the next speaker. The speaker and the last but not the least is the Professor Kim Nelson from New York. Who is going to talk about tinnitus and venous disease and the vascular treatment.
It's a little atypical topic for me to be speaking about. I guess I gave a talk here a couple of years ago on dural sinuses, dural fistulas, and in discussing this with Luis, I guess he thought I had a particular interest in venous stenosis. But in actuality, strangely enough, it has weighed into our practice at NYU. We started a pulsatile tinnitus clinic a number of years ago just to address and to harvest a number of patients that mostly are on the arterial side. So they're lesions that are basically fistulas or aneurysms or stenosis in the petrous segment of the carotid, these kinds of arterial lesions. And this is like one of the typical ones, dural fistula, transverse sinus. We had gotten in later years into basically doing a lot of physiologic interrogation, looking at venous sinus pressures and doing all of these kinds of things. It came to us that instead of closing sinuses down, that ultimately you could use stents and balloons.
Ok, bueno, buenas noticias. Prometí un virus, ¿verdad?
sinuses and preserve the veins. And this is one of these cases. So after we do our physiologic monitoring, we would typically put a stent into the sinus across the areas of shunting, do the microcatheterization on the arterial side, and then sometimes once we selected, understood exactly what the fistula point was, we'd inflate a balloon there in the sinus to try to than the stent. And then we would inject the glue. And the glue, finally, when it gets to the venous side, it interacts with the balloon and it pops the caustic material that Cordis makes, or cotton now, I guess. But that's how we would know that we were on the venous side. And you end up with some nice results, closing fistulas, preserving sinuses. And these are fairly stable results. So along the lines, we started seeing a number of clinical patients that would come to us with the same kind of complaint, a pulsatile tinnitus. Less commonly, it's difficult to auscultate them. However, the first patient that kind of aggressively entered our clinical fold was a woman that had actually recorded. She did so by removing the bell on a stethoscope and putting it in the external auditory canal. And when you let me do that, it was amazing how loud it was, even though you couldn't auscultate it over the mask, because there's no arterial. So, yes, we had paid lip service to people with large jugular bulbs or diverticula of the sign, but normally we weren't really treating these lesions. And so we started imaging in the transverse sinus or the sigmoid sinus. And what's interesting about this spectrum of clinical presentation is there's a lot of overlap. I think as someone suggested a minute ago, that there is a sort of chicken and egg phenomenon. You have this entity of intracranial hypertension, and does the hypertension cause stenosis of the sinuses, or is there an intrinsic stenosis of the sinus that then is affecting CSF resorption, and you end up with secondary intracranial hypertension? And so we have a couple of cases that illustrate both of those phenomena. So I'm just going to go through a series of things that I think kind of illustrate the complexity of the overlapping symptoms in this arena. So this was the first, one of the first patients we treated, a 66-year-old woman with an isolated, severe, life-altering pulsatile device. They can't sleep well at night. It's kind of difficult. She didn't have any headache or visual change, and otherwise her health was pretty excellent. Now, diagnostically with this entity, you can actually fairly consistently eliminate the tinnitus if they can, if you can auscultate it through their external auditory canal, or if they can intrinsically, subjectively hear it, by just compressing the ipsilateral jugular bulb. And then sometimes when you compress the opposite side, it exacerbates the noise. And so what you find classically is this kind of sort of stenosis in the sinus. And it takes a little bit of a leap of faith, like, do you want to really aggressively go after this kind of lesion? Except the patients are pretty strange, they're pretty persistent because it is affecting their lifestyle. And so try to reassure them that it's not life-threatening disease and all of these kinds of things, but they can be pretty persistent. And commonly we find kind of lesions in many of these patients. So in this particular case, she had all of the physical findings on our test technique. Now, we basically have been pretty reliably measuring pressures, because before I get into stenosis, you have arachnoid granulations here, and all of this question is this a hemodynamically significant lesion? And so commonly we will measure pressures with the pressure wire, the volcano wire we use. There's, I think, 2 others that are available, but this one I think is the easier one to use, and at least they have a reliable sales rep that services us. So you can take the pressures, and commonly what you'll find is sort of a 10 to 15 millimeter gradient that is pretty focal at the stenosis. So as you pass the wire, like in this case, you get about a 10 millimeter gradient drop right across that spot. And so with all of these new technologies, all of the great distal access that we use in pipeline, you can apply those tools to the venous side. And now, as opposed to some of the older days where it was difficult to deliver some of these stents, you can take the Neuron Max up to the jugular bulb, and then take take it up over a, either a neuron catheter or, one of the other catheters, and be really in position to deliver these stents. And I typically use the Precise stent, just from the carotid days. I think it's pretty reliable, it's pretty easy, I can understand it, and so I typically like that stent. And this is the result you get. You get a nice dilatation of it. I typically will keep the patients on a sort of similar Plavix regimen that I use with Pipeline until about 6 months in, and then I move them to every other day Plavix, and then 1 year I finish the anti-platelet coverage. And so what's interesting about this is, yes, we have a nice anatomic dilation, but also there's some physiologic consequences. So the image here on the left shows the stenosis. This is before dilation, and you can see that when you do a right internal carotid angiogram, the venous drainage is going out both sides. Okay, so after we stent this open, it's now just able to exit exclusively to the right side, and so there's been a hemodynamic change on the venous side with this. And then clinically, pulsatile tinnitus completely resolved, patient happy, and back to being normal. The more of these patients that you see, though, you start to understand that there's like kind of a triad of clinical issues, some of them associated with intracranial hypertension. You have the headaches, you have the people presenting with pulsatile tinnitus, the people presenting with papilledema, the people presenting with all three or two of these symptoms. And so it gets a little complex and a little difficult to ferret out like which patients are going to benefit from this, and some of the imaging can be somewhat helpful. This is another patient that we had that was plagued with a recurrence of some of her symptoms. So it's a 43-year-old woman, typically the typical obese patient, comes in with intracranial hypertension. She has a loss of peripheral vision, enlargement of the blind spot. She has the papilledema, severe headaches, pulsatile tinnitus. On a lumbar puncture, her opening pressures were elevated. So it's the classic patient, and you do the MRV, and you can see that bilateral stenosis here. And so we decided, but there's a little bit different quality to this stenosis. If you look here in the lateral, you see it's sort of like a scalloped appearance of the stenosis here. And I think that this has something suggestive of an extrinsic compression from the elevated pressures. So again, we went ahead and did this on one side, and again you see this sort of scalloping here. Instead of that focal stenosis, this is a scalloping effect. But you can dilate that up, and a stent will hold it up because these are fairly robust devices, and so they can open it up. Immediately after the procedure, her pulsatile tinnitus is gone, headaches resolved, papilledema improves, but 12 months later, she comes back in partially. So she has her headaches back, she has papilledema again, the pulsatile tinnitus is gone. So the stent, there's no stenosis there, so you don't have the turbulent flow, but there's another cause for her hypertension. Now, you could say, is there like another stenosis a little further out? I'm not sure. We tried to measure pressures across this. It didn't seem like it was a hemodynamically significant focal area of stenosis. So we just basically left her untreated. And basically, essentially, all we ended up managing here was the tinnitus without affecting, in the long term, the headaches or intracranial hypertension. And I think she went on to shunting. So the imaging findings, I think, can be a little bit used to distinguish among the patients that have intrinsic stenotic disease and those that have secondary stenosis related to elevated intracranial pressure.
Jenny?
Another patient with residual narrowing after a VP shunt. So this was a young woman with a normal body habitus, severe headaches, pulsatile tinnitus, papilledema with visual changes. She ended up with a shunt, helped her out in terms of the headaches and the visual. So vision normalized, headaches resolved, but she still had a pulsatile tinnitus, and she actually felt that it was a little bit worse than it had been preoperatively. So now we were just going to do this, because of the tinnitus. And here on the MRV, you see, there's a fairly high-grade stenosis there in the transverse sinus on the right side. And so we end up coming here. The angio, interestingly, doesn't really show as, you have to kind of like angle it just perfectly to illustrate that. I think the MR is sometimes a little bit better at localizing it. We come with a pressure wire. right there at the spot of stenosis. It goes up. You know, there's a pressure gradient. The torcular pressure is obviously high, and so then we ended up stenting this, and with a nice resolution of the tinnitus. Now, she had already been shunted, so I can't tell you whether or not the high intracranial pressure had anything. But at the time that we did the stenosis, even though the stenosis was also a little scalloped, the intracranial pressure was normal. So this was basically done just to relieve the tinnitus. And then you have some patients that are a little bit of a mixed picture. And a 43-year-old woman, normal body habitus, history of headaches, neck stiffness, severe left-sided pulsatile tinnitus. You can have one of the really fancy stethoscopes. It's abolished by jugular compression. She has papilledema, but her visual exam is still normal, so it's in the early stages. Opening pressure is 30, and you know, this is, I actually have started doing this more volumetric post-contrast T1s, because I think they sometimes the MRVs can overestimate the degree of stenosis. But here you see like some nice you know, high-grade imaging that gives you some impression of it. The other thing that we like to evaluate when we're doing the imaging is for the collateral circulation, because many times you're jailing like a dominant Lebet, or like in this case, and so there's always a question: is that venous drainage going to go down, and you'll end up with a venous infarction? Attention to what is the potential venous collaterals to this jailed vein that you're going to be dealing with. And in this case, you see there's a connection here with the superficial sylvian veins. You know, but it's worthwhile paying attention to this before you get into trouble. And sometimes we backed out of cases that really had dominant Lebets that were the primary drainage of the whole hemisphere. And so this was another case, stenosis. We ended up going across this. You see it on both the posterior circulation and the anterior circulation, and the lesions are bilateral. There's about a 14 millimeter pressure gradient across this, and you can get a nice trace. And you see how abrupt it is. It's, you know, if I actually have the, you know, it's not something that you go from the jugular bulb to the torcular, because obviously there's going to be a little bit of a pressure gradient there for blood to move in that direction. But this is like a focal right at the stenosis. As you pass it with the guide wire, you'll see this jump in pressure, and also notice how it gets a little pulsatile on the proximal side. So we ended up going ahead and stenting this one, and the pulsatile tinnitus was gone completely immediately. Papilledema resolved, but the headaches really kind of remained unchanged. And so that's like an uncoupling of yet another symptom in this triad of conditions that they can end up with. So we re-imaged her. You know, this is just an MR. It shows the stent placement. There's a flow through the stent that seems somewhat normal, and I can't really explain why the headaches haven't resolved despite the other symptoms going away. So the key points in the takeaway message is ipsilateral jugular compression is very useful in sort of physical kind of examining the patient and suggesting a venous level, a venous cause for stenosis. The stenosis can be either the cause of the intracranial stenosis, or it can be the effect, and I think there's some imaging features that are suggestive of those different subtypes. The morphology of the lesion can suggest an underlying, whether it's smooth or irregular. Pressure measurements, I find, are very helpful in confirming that it's actually a stenosis and not just an overgrown arachnoid granulation or something of that nature. And so we really look for that focal pressure drop. Thank you.
Thank you very much for your interesting presentation. Is there any question in the audience? Yes, please.
Just to supplement, I had a very similar situation of a benign intracranial hypertension, a young lady presenting with papilledema, and when the imaging was done, she had an unpaired transverse sinus, and on the right transverse sinus, which was the only transverse sinus, she had a intra-sinus meningioma. And she was going from one surgeon to the other surgeon. She was fully preserved. Nobody was ready to operate upon her because this was an unpaired sinus, and nobody had a courage to take a chance to open the sinus and remove the tumor. So finally, this lady landed up to me, and we did an angiogram. We have some cases of meningioma where we have done therapeutic embolization. About
shrink them.
Maybe
Yes.
18 or 20 cases that we have. So this was a very interesting case in that sense that the whole supply was from the transmastoid branch of the occipital artery. So just under local anesthesia, we did a therapeutic complete embolization of this tumor. And I think in about 4 months' time, 4 weeks' time, less than 4 weeks' time, she had a complete regression of the papilledema. Her headache subsided. And we have a documentation of a tumor shrinking completely to at least to less than half of the size of the initial one. So this was a very interesting case example that stenosis is probably the cause and not the effect.
Yes.
Of this all benign hypertension.
Yes, it's a nice anecdote to sinus issue. And I think that's true of a number of the patients. So it's distinguishing those patients that becomes now the challenge. But very nice. Are the Brazilian stepbrothers in the audience? I see one. Where's the other one?
Not here.
Early desesperado.
I have a question. The majority of the cases that you have presented were patients with benign intracranial hypertension.
Yeah.
In which percentage of patients with pulsatile tinnitus did you found venous abnormalities that can be the cause? It's very infrequent.
So
isolate
so
tinnitus.
that's an interesting question because I don't know what the denominator is. We're seeing patients because of their pulsatile tinnitus. When it's a venous cause, it turns out that about 2/3 of them also have intracranial hypertension, but some of them don't. I think if you went to like a papilledema clinic or a venous, you would see something else. And so I don't know what the answer is. The patients coming to us, many of them have intracranial hypertension, but they also have the tinnitus. And so they're all seeing us because of tinnitus. We probably could get at that by going out to some of the neurologists and ophthalmologists that are managing those patients for principle. But they don't really get to us unless they have the tinnitus.
Please.
Do you think to study also the extracranial veins when you should have, for example, transverse sinus stenosis, to add also the extracranial studies?
So some of them, I don't know what to make of it. Like we typically record it. So some of the patients, they'll have prominent transmastoid veins or suboccipital veins. And you can tell that because of the stenosis, they're utilizing these accessory venous channels. Not all patients have it, but some do. And interestingly, when you stent that, just like I showed on the first case where now the venous drainage is going ipsilateral instead of bilateral, that also tends to regress to some degree. Anecdotally also, just in doing a lot of angiography, we do find patients with more proximal jugular stenoses or distal sigmoid stenoses. And those patients inevitably will have like suboccipital veins that drain into the paraspinal space and that sort of thing. So, like analyzing the venous, as you've made a career of this, I think we're in an early stage of starting to appreciate the variability in the venous anatomy and also its implications.
Thank you. I think it's time to close. It's very late. I'd like to thank you, all of you, for attending. Yeah, sorry.
Bachelors?
Oh.
Dr. Nelson showed this case.
This case here? I want to show us here. I don't feel it's fair that you come here and open up your kimono and then I have to just sit quietly. But if anyone wants to see some basilar cases, I just have a couple of 0.7 cases to show. If you want to sit, or you can, vamonos. So this was back in the old days, and it's a mid-basilar in a guy coming in with cranial neuropathy. And you know, we had just gotten the Neuroform stent. In fact, it wasn't released in the States, so I had to get a couple of experimental devices. And what we ended up doing for this thing, and you see it's sort of enveloping the mid-basilar artery. But retrospectively, at the time, we were very impressed with ourselves. But retrospectively, it's kind of a simple aneurysm in the sense of the segment that it involves. You see, it's beyond the ICA. It's between the superior cerebellar and the ICA, and it's impressive. We ended up overlapping two. Well, first, I coiled it with balloon remodeling because I didn't want to have to negotiate going back through the stents. And then we dropped in two Neuroform stents, overlapping them. And basically, this was the immediate follow-up angio. This is like 3 years later, the MRA, the MR, you know, for there. And the guy's done really great. This is now over 10 years out, and you know, it was just an exciting case. This represents our pipeline series. And the point I just want to make here is this is through May of 2013. We had done 58 cases. Now I think it's over 70, but this was when I was here before in Madrid at a conference. I was showing this data, and I happen to have it on my computer. The important group that we've been talking about today is this group of 13, the basilar that's ICA inclusive, so the basilar fusiform, not the other basilar terminus or proximal VB junctions or any of these distal verts, because those are actually fairly easily handled. And so if you look at the aggregate data, and now we, you know, 6 of the patients died. 1 of them was so neurologically impaired they couldn't come back for an angiogram. But there were 51 patients that did come back, and we had 78% occlusions. We were sort of happy with this. And then our morbidity, if you look at the aggregate, it's around 20%. Serious morbidity, 12%. But that's all comers. So if I look at the serious morbidity, 6 deaths and 1 major stroke, that's that group of 13. So it's over 50% in the group of 13. And so this, going back to, and this is not part of our database because I did this at the Cleveland Clinic with Dave. This was that first one that got us all excited. I showed it this morning, big fusiform. We used 7 pipelines here. We like overlapped them. I had a distal, 1 pipeline distal, 1 pipeline proximal, so the normal vessels are covered just with single pipeline. And then across the aneurysmal segment, we stacked up another 5. So it's very densely stacked over the aneurysmal segment. This is what it looked like a week later. And then you see 8 months or 9 months later, the mass has even gone away. And that's really what has to happen for this to be cured. I was interested in 2 of your cases that you showed, one where you had the delayed rupture, and the second one where the woman's aneurysm now has gotten bigger, despite the fact that angiographically it kind of looks close, because that's what I was alluding to this morning with the ophthalmic that I treated with the single device. Angiographically closed, but the thrombus is growing, because the thrombus is like a fluid, and it's still in hemodynamic exchange with the flowing blood, because you haven't sealed off the base of the aneurysm. And that's why I think I'm a little concerned that we need to have actually more coverage to support the intimal overgrowth of these lesions if we're going to cure them. So a week later, I was in Budapest, and I did this one with Istvan. It was a young kid, soccer player, you know, came in a little clumsy, and so we ended up treating him, and he had a great result. But again, you see it's the same kind of thing. Very impressive, large mid-basilar aneurysm, but it's between superior cerebellar and the ICA segment down here. And so this now theoretically, fundamentally, I know this can be treated very nicely with flow diversion, because we've had several of these kind of cases that have done quite well. Here he is a year later. It's really great. Back to playing soccer. Good story. Everything's fine. This was a young woman too, but she had had a deconstructive procedure about 8 years earlier. The thing recurred, came back in, again, sort of massive aneurysm. The MR I don't have. It was done at the University of Wisconsin. It is very, very impressive aneurysm. We ended up pipelining this. I think I used 4 devices overlapped. It's had a little fenestration here at the proximal basilar, but again, you see it's proximal to the ICA. So I could anchor the construct with a single device across the ICA, sort of reducing the likelihood that I'm going to have a thrombotic complication. And then you don't have to cover the pica because that's way down low. And so you can make a very heavy construct And this is the result you end up with. And you know, she's been followed out to 5 years now and has done very nicely. So I was very enthusiastic about this until this patient rolled along. And this was a gentleman that had a grade 1 subarachnoid hemorrhage. And if you look at the MR, you know, you can see that the wall, there's mural hemorrhage in this aneurysm. So he was seen in a different U.S. state. No one wanted to touch it because of a very complex aneurysm. And ultimately, in a subacute fashion, he ended up coming to New York. And so this is what we found at that stage. And now he's about like 3 weeks out of his original hemorrhage. And you see this kind of a lesion. The vessel's irregular all the way back to into the left vert. It goes up into the basilar, and unfortunately the icas are coming. This ica here, the dominant ica here, is coming from the sac of the aneurysm. So we were a little timid about drastically covering this kind of thing because I didn't want to close off his ica. The other thing that was kind of curious about him is right at the VB junction, right where his right vert comes into this VB junction, he had a tuft of medullary perforators. And so I didn't want to close that vessel down. And so what I did is I sacrificed it down below the pica so that it reversed flow in that right vert. So we sort of understented him. Now, in those days, we only had the 20 millimeter long pipelines, so you had to overlap them, you know, 50%. I think we used 4 devices to reach across. And the average coverage, because it's 50, each one is 50% overlapped, is about 2 stent fold. So it's about 2 stent coverage. He did remarkably well. So you can see, like, even after we're done here, immediately post, there's not a lot of flow. There's a little bit of flow diversion. You see the contrast hanging up, but it's not horrific. You know, it washes out. In the venous phase, there's a little bit of residual there, but you know, it's not like we normally would see in a cavernous segment aneurysm where we use 3 stents. So this is CT post-op day 1. Everything looked okay. I didn't think we were going to get into mass effect problems with him, but well, I didn't know about that then. I was operating as if we could just stent these things. And so this was okay. We got a CTA 3 days later, and the aneurysm is mostly thrombosed, except up here where it's running off into the ica. And so there's a little sac of residual neck that I think Jacques was showing this morning. I don't know what he calls that, sort of like exit, an antechamber into an exiting vessel. Then we were 4 days into the 4th morning, we were rounding, and he was brushing his teeth, speaking to us in the emergency room, and he dropped dead. And he was coded within like 30 seconds, and he did not survive this hemorrhage. So it was an abrupt hemorrhage. The next patient that came in is a slightly different variation, a guy getting progressively worse. He's now kind of quadriparetic, can move, but he can't stand. You know, had been followed for a long time down in North Carolina, and ultimately made his way up. You can see most of the aneurysm is thrombosed, so it has a big mass effect there. We ended up also, because the icas are coming from the belly of this aneurysm, we understented. So it's again just, you know, sort of overlapping 20s. So you have about an average of 2 stent coverage going from distal to proximal, and then we closed off the vert. Now, again, the same problem was there were perforators in that right vert right at the VB junction. So we did the same thing of closing it down below the pica, which was extradural on that side, and ended up like this. So everything actually worked out okay for this guy for a little while. We had him back 1 month later for an angiogram, and this is what it looked like. So angiographically it looked good, and it actually, curiously, the right ica seems like it's coming right off the vessel. But we know that's not true, because what's happened is that, like, if you do the CT, there's a big mass there still. So this is just a channel going through clot that then is exiting into the ica. And I think that keeps the clot alive, and that can lead to some problems. So in this case, the aneurysm mass kept growing. He got into hydrocephalus, but he's on aspirin and Plavix. So we tried to wait him out until 3 months. He was on Diamox, steroids, mannitol periodically. And finally, we felt comfortable enough, actually, back in North Carolina, they felt comfortable enough to take him off the Plavix for a few days, put the shunt. Everything did great. Everything went well, except that from the shunt, he ended up septic. and died, about a week after that. So that was a little disappointing, but we learned something that at that stage that we had to start shunting preemptively, because once the patients are on aspirin and Plavix, you really have very limited options to sort of change that. And all of these interventions, craniectomy, shunt placement, that can all be somewhat morbid. Then this patient was sent to us. So, now we're kind of a little bit more savvy. We decided we're putting the shunt first, and we're getting ready, and she comes in, again, similar kind of thing, not as bad off as the previous patient, just a little bit of weakness, kind of a little ataxia or difficulty walking, has to use a walker to get around, and was interested in being treated, and so we ended up doing this. It was a little bit cumbersome to build the construct, but again, sort of under-stenting, about an average of 2 stents going across there. Here you see the coils in the vert on the right side, closing it off. And this is the immediate after effect. You get quite a bit of flow diversion because it's a big aneurysm sac. And this is 24 hours later. We were very impressed. We thought this was going to work out nicely. This first diagonal of CTs are the CTs right before treatment. And you see that basically you have, this is the shunt that had been placed for us. And she has like some existing hydrocephalus even with the shunt because they have it, pressure related. But then this is 7 days after treatment. You see the hydrocephalus seems to be resolving. So we were really thinking this is going to be a great success. 2 weeks later, she rolls back into the emergency room like this with a rupture. And we knew that this aneurysm, even 24 hours later, was almost completely thrombosed. So thrombosed aneurysm can still blow. And so that brings us to ultimately, and I've done a number of these cases internationally too now, so I slowly have evolved to a different philosophy from yours, and that's why I'm showing these cases, because these are a couple of the survivors. Now, I'm not saying they're happy, because they were coming to us basically in a stretcher. Well, that's a good point. We generally do pretty, like here, there still is a little leak. But this is only 24 hours later. So this is a little leak into, still some persistent leak, but most of the aneurysm is thrombosed at this point. Now, soft thrombus, hard thrombus, thrombus is really, it's a biological material that turns over. And so I think of it as a dense fluid now. And it may conduct the pressure wave, the transverse pressure wave, more efficiently than swirling fluid does. And so, these are issues that still have to be resolved. Educated gentleman who did an insane amount of research. I first ran into his films at the University of Michigan, where he had been up to just to be angioed and tested. Then I ran into him at the University of Toledo in Ohio, and then finally he decided that he had gotten bad off, that he was just going to come to New York and get treated. So they brought him by ambulance, and it's a massive aneurysm, again, mostly thrombosed. But just to show you how we're building the construct, so many times I'm actually building them proximal to distal. And so I start off here, and that lets you seat the proximal construct ideally, and then you can add stents as you want. But I've changed our approach to being just now more stents. Now, ironically, at these very advanced stages, many times the patients have already closed their ICA, and that can be favorable. Sometimes they haven't, but sometimes they have. In this case, he had one ICA was closed, the other was still small. Nevertheless, I've made the decision that I'm just going to take the chance, and hopefully they have some collaterals at this point. And so we go ahead and we build this. As I get close to the distal end of the aneurysm, then I drop a more normal size stent into the PCA, so I don't dramatically oversize it there. And then I finally bridge the two with another stent to connect it up. And so this is ultimately, this is in the AP view, this is in the lateral view. Now his basilar is turning upside down, and then it bifurcates over here where this is, and this is going out the PCA. So it's a thing that's almost doing a 360. And so this is how the construct looks in a 3D version of the aneurysm right after we've finished the construct. And kind of like you're applying, I mean, it's very dense over some parts. It's a little less dense over other parts, and so that could be a problem that has to be addressed. But the other thing that I've started doing now is coiling. So up here where I had that open area, I've come and I just coil it. And I just coil this too, because what Demetrius was saying earlier on about the question of we don't have control over the clot, I agree. And I think some of our early ruptures where we had thrombosis of the aneurysm and then it ruptured kind of proves that out. So I think coils may be useful in stabilizing that thrombus. And I think, but I still believe that the flow diversion stent or the high coverage stent is a little bit more efficient and a little bit more likely to allow the thing to heal. Now, why so many stents? Because ultimately, if you're going to come to cure, it's got to be able to conduct the enema over the whole construct. And I'm just not secure that a single device does that, at least a single pipeline. Maybe a Surpass does, but I don't think a single pipeline is capable over that large a distance where it's just floating in the breeze. And so I want to have a lot of construct to support entemal overgrowth, and it still may take a year to 2 years to finally over-entomalize. And so this gentleman actually survived. He improved enough to kind of sit up in a wheelchair. He's not perfect, but his family's very happy, and intellectually, of course, he's still okay. So that was a very good case. This is another case, and I guess I'll end with, I'll probably end with this one, but a very similar case. Now, this patient had had a surgery. They attempted, I don't know what they were exactly, they were going to somehow clip this thing or clip reconstruct or deconstruct, I'm not sure, backed out of it, and he was left with a hemiplegia from that. So he already came, missing his ICAs from that. So in a way, it was a little bit of an easier story, despite the fact that it's this monster. And so we ended up going here, and just like the last case, building distal, proximal to distal, and then after the construct is built, kind of adding a coil pack to here, just so it doesn't rupture, it more quickly thromboses down and closes. And so this is the result from this one. And the gentleman is not perfect because he came to us with a significant deficit. And actually, I'm sorry, this guy was fine for about almost a year, and then he died of cardiac failure. But he came with a cardiac output of 15%. And so this is the gentleman. So he ends up passing away of the other things. And that's why, as I said this morning, I think of, when I'm treating these patients, I'm almost thinking like an oncologist. I have a window. If they can survive a year, 5 years at this stage, I consider it a success. And so, but no, I closed the vert. I closed the vert on this guy. Yeah, I coiled the right vert. So this is the left vert coming up and swinging around and going up. The other vert's already closed. It's in this coil mass. As it comes out, it comes into the vert. See, the original vert comes in behind here. So we coiled the aneurysm from the right vert and brought the coils down into this right vert. So I use it because I'm using pipeline, and I agree with you. Like, I think the staged approach, if you're using low coverage stents, that can be useful. But when you're with a pipeline, the flow diversion, I'm a little bit like Ricardo. I close the other side. But just to remind you, okay, patients, you have other approaches. This was a woman a number of years ago that we did kind of a deconstructive thing. But again, this is, here the ICA is up here. So it's not exactly the same disease. We were very impressed with it. We did a bypass into the PCA, coiled off the sac of the aneurysm, and the basilar fills down to the ICAs. So there are deconstructive approaches. And this patient did great until exactly 1 year to the date. She came back in dead from the bypass closing. And so, it's not, everything has its morbidity. Thank you. But I thought that I should go over some of these cases since you guys did such a good job.
Thank you.
Yeah.
Delayed perforator thrombosis.
10% in our series. Now, what's interesting about that, I kind of was curious about, Not so much with these cases, strangely enough. It's with our other cases, like the basilar apex aneurysms and the others. So we have, in that little group of 50, actually it's 40-something of the, well, now it's more of those kind of basilar tips, BB junctions. We have 10% perforator injuries. What's curious about them, every single one of those patients, and there are 4 of them, no, 5 of them, every single one is a heavy smoker. Every single one. Every single perforator injury is about 3 to 4 weeks out. Every single one of them. It's not like the next day. It's not 2 days later. It's 3 to 4 weeks out. They come back into the hospital with an issue. Now, 2 of those patients were locked in, and the MRs looked terrible. Every single one of them recovered. Shocking. I had 2 of those patients intubated on phenobarbital, coma, for a week. And then we let them emerge, and they started recovering. And every single one of them got back to baseline. And so what's interesting, I don't know what kind of perforator injury it is, but it's a delayed perforator injury. They're all heavy smokers, so I think that definitely is a risk factor if they're smokers. And they're delayed, so you have to kind of expect it. You have to be vigilant going out a bit of time, because on 2 of the patients for sure we were about to just sign off on them, and the neurologist thought we were nuts for pushing ahead and doing the whole phenobarbital.
And the second question is delay aneurysm rupture before and after you start using coils.
So so the 2 cases that I showed of the ruptures all happened. The latest one was 2 weeks and the other was 4 days out. So they're not like a year out. But I imagine I think that's been reported actually. Somebody had it.
But both of the 2 ruptures with no coils. So for the patient
the 2 ruptures were no coils and what I consider understenting, because we were at that stage worried about perforators. And so we were understenting the 2. What got me into the heavy constructs was a case that I did at Cambridge, and then another one that I did in Thailand. And in those cases, we just decided, because the way the patients were, to do heavy stenting, because already I had some bad luck with understenting. And the patient at Cambridge did quite well, despite the fact that both ICAs went down. And at least we didn't even know they went down until she came back for a 6-month follow-up angio. The patient in Thailand closed acutely one of the ICAs and ended up with a hemiplegia. So, I don't know, it may be that to cure this disease, you've got to take the ICAs at some stage. And maybe with flow diversion, you have the option that it closes a little slower, and maybe they have some potential to develop collaterals.
See, this is because I'm trying to summarize the day-to-day.
Yeah.
We start with that hybrid approach now, heavy stent, like we have this 2 and we don't get anywhere rotation like that.
So what I was going to also say, Ricardo, your observation about the Buffalo series being 5 stents, don't forget that was when we had short stents. So 5 stents to cover some of these giants is nothing. I mean, it takes 4 stents to even just get across the end.
My point is
the short.
That's what they are generating. That's the point. About the 5.6, because you're creating these windows of single double, single double, single double.
Yeah.
It's a mess.
So maybe that's where coils help you. So if you still, I aim for between so that little window is 3 stents. I aim for 3 to 5 stent coverage when I'm doing this. So it's pretty heavily covered, even where it seems like it's a window. Nevertheless, it's the same problem. So that's why like you say, it makes an ugly picture. But I think that I've kind of become a believer that you have to also coil these things.
Yeah, I don't think that the issue is only the coverage of how many stents used, but the curvature, how many alters.
It's fine. It's fine that you close your computer, because in other case, this should be like a music concert and they ask for another song. It's time to, I ask for an applause for Luis, that is not here, but for organizing so interesting journey.